So it is Thursday. It is the last day of the week for you guys. Whoop-ha. And it's about 1:08. We're going to get started in Therex talking about stuff that we did not finish last time on Tuesday about the hand therapy and neural type stuff. So the last thing we finished off with last Tuesday, gee, I scared somebody off, is thoracic outlet syndrome. And we had talked about the way that the anterior scalene had kind of pinched down on stuff. And again, like I said, a lot of times I actually have a bunch of therapists that watch my videos. And usually after they watch the video, I usually get a bunch of emails giving me hints and pointers, which I actually appreciate. Thankfully, they don't correct me on the in the YouTube comments, because that would just be embarrassing. But one of the things one of the hand therapists wanted me to mention to you is, while the thoracic outlet at the neck is really important, hold on real quick. So John said he can't find the PNF lecture. Let me just make sure I unlocked it before I go. I'm pretty confident I did, but maybe I didn't and my brain is not working. Hold on. Hold up. Wait a minute. Something ain't right. I'm moving stuff around so I can get to the right part of my page. 205, there's therapeutic exercise. I swear I made a student available, but you know, I am getting senile, and you are correct. Oh, yeah. There, check it now. I'm an idiot. It's available now. Good news is we didn't start it yet, so I can fix it before we get started. So anyway, back to the thoracic outlet comment I was making. So I had a hand therapist. Thank you for correcting me on that. I appreciate it, John. Keep me on my toes. I had a hand therapist that talked to me and said, you know, mentioning not only that kind of that scaling triangle that happens there, but she also had mentioned that not to forget that on top of that scaling triangle, right below that scaling triangle is what they call the rib circle. And the rib circle is this little ring that's formed by a space of cartilage that allows blood vessels to pass from the heart out to the arm. And said that most of the time when we have thoracic outlet problems, it's definitely in that scaling triangle. But sometimes it can be ribs 1 and 2 that are causing the problem, which is why we do those rib modes that I said we were going to talk about. But you know, sometimes those vessels kind of dive through that scaling triangle and pass down through that rib circle. I didn't know that was actually a term, but evidently it's called the rib circle. It's this little kind of ring that sits right about here. And sometimes that area also pinches down. So if it's vascular, the first thing they clear is that scaling triangle. The next area they clear is that rib circle. So she just wanted me to stress to you that it's not only this. And I'm like, well, they're kids, they're just learning, so don't totally freak them out about it. But she's like, it's kind of important if any of them end up in a hand therapy clinic to understand that it's not just up here, it's a little bit down here in the ribs area as well. So I appreciated the feedback, which is what led me to the feedback on MOBs. So CTS is probably one of the most common things we've heard about, right? I mean, if I ask, I'm pretty sure all of you have heard of carpal tunnel syndrome, and I'd be willing to bet probably about at least 30% of you have had some form of carpal tunnel syndrome at some point in your life. Just because it's a really common pathology that happens when that carpal tunnel kind of swells up. And the one thing that always struck me is that picture that's up in the upper right-hand corner, because that carpal tunnel is not very big, right? And when we're talking about the actual true carpal tunnel, we're talking about this section that sits just anterior to those bones, right? To the hamate, the capitate, and everything like that. And through that, we've got a whole slew of tendons that pass. We've got a whole slew of blood vessels and a whole slew of nerves. The main nerve that passes through there, obviously, is our median, right? We also have some anterior cutaneous nerves that pass through there as well, but that's neither here nor there. But that median nerve comes down here and innervates these primary 3 fingers. So a lot of times when a PT evaluates a patient, what they'll notice is that the patient's lost some function in the thenar eminence, right? So going back to anatomy, thenar means thumb side, right? So the thenar eminence is this bump right here below your thumb. Does anyone remember what the area underneath your pinky is called? If this is the thenar eminence, does anyone remember what this area is called? I don't think we learned it, okay. So this is thenar, or thumb side. I don't know the reasoning behind this, so please don't shoot me on this, but this is hypothenar. So below thenar eminence. It's not really technically below, but whatever. So thenar is thumb side, hypothenar is pinky side. So if I'm typing that out to you, right? So thenar, hypothenar, right? Often tends to end up with some problems with abductor pollicis brevis and opponent's pollicins. So a lot of problems doing these type motions where you're moving away and coming back across. You can also lose the first two lumbricals, which are inside the palm here. Sometimes you'll also end up with a little bit of anatomical snuff box wasting. Does anyone know where the anatomical snuff box is? Did Dr. Johnson talk about that? Because I'd be surprised if he did.
Isn't it like that little crevice between, like if you do the OK sign, like right in between your finger and your thumb?
Yeah, it's right in kind of here, right? Why is it called the anatomical snuff box? Does anyone know?
Because that's where people used to do snuff from.
Exactly. And now we do other stuff from there, so I hear, in Las Vegas. Right? So that little kind of area, we can end up with some wasting in there as well. So if we get positive clinical findings, so atrophy, weakness, a positive valence test, which we'll talk about valence in a little bit, some loss of two-point discrimination. Remember, two-point discrimination is where you take two sharp objects. I've only got one here. I don't have another pencil handy. And you spread them apart and you keep moving in closer and closer until the patient can't tell that there are two spots. There's a specific degree at one point where I believe it's 20 millimeters or something, don't quote me on that, where they say if you have, if you can't detect at 20 millimeters, then you've lost two-point discrimination. Positive carpal compression test, if you squeeze down and the hand goes numb, that's another thing. A positive Tunnel sign. Do you guys know what a Tunnel sign is? Have any of you heard of that before? Tunnels is kind of neat, because there's Tunnels of not only the carpal tunnel, but also the ulnar nerve. So Tunnel sign is if I've got a problem with my carpal tunnel here, I take a pointy finger and I keep tapping on my carpal tunnel. And you tap and see it. Oh gosh, there it went. Got a shock. Ow. Shouldn't have had a shock. That's weird. I did that on that hand for a purpose. You keep tapping there until you irritate the nerve, until something goes numb. You can do it at the elbow. You can do it at the intercubital fossa. So a Tunnel sign is just tapping on the nerve to see if the nerve gets irritated. If it doesn't, then it's a negative Tunnel sign. If it does get irritated, it's a positive Tunnel sign. When we are looking at the carpal tunnel, also when we look at the ulnar nerve, we have to clear all of the areas above it, because in order for it to be true carpal tunnel syndrome, the problem has to be here. It can't be up here in the intercubital fossa. It can't be up here in the neck, right? For true carpal tunnel syndrome. But all of those areas are areas where a nerve branch is passed down to get down to that median nerve. So we have to clear them first to make sure they're all okay, so we can finally get down and say, yes, it is a carpal tunnel problem. It is possible to get this thing called a double crush injury, where you end up with nerve symptoms along multiple spots of that nerve. So I could end up with a pinch on the carpal tunnel up here in the brachial plexus, but I could also end up with a pinch down here in my wrist. That's going to kind of double the effect of that feeling, right? So I could end up with, I fix the carpal tunnel on the patient. The patient's like, yeah, but I've still got weakness and I still am missing sensation. And we go up here and go, oh God, he's still got some compression up here, got some compression in the intercubital fossa. So we have to kind of test the whole way down and make sure that everything is clear once we kind of fix the patient. We get increasing pain, paresthesia with the hand's repetitive use. And again, that is the presentation of the carpal tunnel. So these three fingers, sometimes a little bit of ring finger. And then sometimes with ulnar, there might be a little bit of middle finger, depending upon how your hand is kind of laid out. We all have a little bit of a different layout of our hand. They usually get irritability anytime they get something where they close off the wrist or hyperextend the wrist, that carpal tunnel gets irritated. They may lose some joint mobility. They may develop some different changes to other nerves in the hand. They may have hyperirritability ulnar nerve along with that median nerve, or the radial nerve along with that median nerve. And it can develop from faulty head posture. If I'm kind of like this and I start pinching off here, I can end up eventually with that double crush injury where it affects multiple parts of the carpal tunnel. Go forward, young man. Oh, I'm on the draw. That's why it's not going forward. So a lot of times you'll have decreased fine motor control, specifically doing like buttoning of clothing, unbuttoning of clothing, controlling of zippers. All of that can kind of lead to problems that indicate they might have some carpal tunnel syndrome. They'll often avoid using that hand because they lose sensation. They can't perform sustained wrist motions, and doing so provokes symptoms. So if you do a lot of somebody, I forget who has said that their sister or whatever is an esthetician where they do stuff with the hands and do nails and stuff like that. A lot of those people, thank you, bro. A lot of those people will have problems actually doing fine motor control of whatever hand is the problem. And so they end up switching hands and avoidance use of that hand. I've had patients that are stuff like welders and things like that, that they end up with problems. And so they end up avoiding using that hand because they just go numb when they're using it. And a lot of patients will get sleep disturbances. It's funny is I had one patient once that complained constantly about, well, she had carpal tunnel syndrome, but it was really only aggravated when she slept. And so one of the docs ordered a sleep study on her to see if it was her posture when she slept. And what we found out is when she slept like this. Like that's literally the way she slept all night long. And if she sleeps like that all night long with that wrist hyperflexed, do you think that's going to cause some carpal tunnel compression? Like, seriously? So we got her a resting splint, kind of like that splint that I was wearing the other day, right? This kind of splint here. And if you notice, because this splint's actually a carpal tunnel splint, if you notice, it's splinted a little bit into extension. So when I put it on, it pushes my hand back just a little bit to open up that carpal tunnel. We splinted her like that. And we actually gave her a solid splint, not a nice soft splint like this, so that she couldn't sleep like that. A week later, she's like, man, all my symptoms are gone. So her solution was we got her a soft splint like this. And we started with a hard splint just so we could really kind of rule that out as the problem. And the hard splint we could make pretty cheap. Then got her a soft splint to wear at night, and she continued to wear that soft splint at night. And guess what? She no longer had carpal tunnel syndrome. It's amazing that something simple like that can fix it. That would be an orthotic. Yes, remember what I said is a splint is another word for orthotic, correct? Right? Now, let me ask you a question, because we're going to talk a little bit about operative management of the carpal tunnel. There is an operative management where they can put in a little piece of plastic that kind of creates a bridge and raises the palmar fascia up off of it. Would that be a splint, or would that be an orthotic or a prosthetic? That would be a prosthetic, yeah, because there actually is a piece of tendon that goes across there that's supposed to do that job. So you're replacing it. Here's my bias on carpal tunnels surgery. Again, much like shoulder surgery, I've seen people that go in for carpal tunnel surgery and come out worse. I'd also like to see the stats on something like bariatric surgery. And so Bianca says, my fiance had carpal tunnel syndrome, they cortisone shot, right, helped the symptoms. Well, it makes sense because carpal tunnel syndrome is literally a neuritis, right, an inflammation of the nerve. So you give them some cortisone that calms the inflammation down, and hopefully then everything else calms down with it, and Oh yeah, right? Could have also done ultrasound with cortisone over that. But my bias here in physical therapy, it is a lot better. That's what I was I was getting there, John. My bias in physical therapy as an old school PTA is that I've seen patients that just have had butchering of carpal tunnel surgeries. If you are going to get CTS, do not just see a regular kind of neurosurgeon or a regular orthopedic surgeon. Make sure you are going to see a hand specialist. If you don't see a hand specialist, that's when I see butchering. You know, hand specialists are used to dealing with all the itsy bitsy parts of the hand, right? Doesn't mean an orthopedic surgeon isn't good, but an orthopedic surgeon isn't designed for hands. It's kind of like seeing a vestibular specialist in PT when your problem is your pelvic floor. Yeah, they probably have some training in it, but it's not the best. Same idea here. For us, we usually start in non-operative with static wrist orthoses, right? Position in neutral or a little bit of extension. And then we're going to work on mobility techniques, right? We're going to work on really stretching out that carpal tunnel so we can open it up and get it nice and stretched out and open. And we're going to work on opening up not only this way, but also opening it up this way so we can kind of get in there and spread open that hand and open up that carpal tunnel so it gets stretched out. But what we're trying to do is loosen up. There's a ligament that crosses right here that we want to kind of loosen up and take the pressure off the nerves and the tendons underneath. If they have surgery in that maximum protection or that acute phase, they're going to be in a super bulky dressing. It's not going to look like this. It's going to look almost like a cast because they've just opened up a neural window and you don't want to bang that off something, right? Patients needs to be educated that they need to control the wound, control swelling, control pain. They're also going to be instructed on doing tendon glides. And so we're all going to do a tendon glide right now. It's called the 6-pack. So they're a little different clinic to clinic, but the hand clinic that I worked at, you're all going to start with your hand kind of straight up, fingers pointed straight up, thumb crossed in almost opposition. So that's position 1. The next position from there is tabletop. So the thumb comes out and the fingers come down. That's tabletop position. No problem, Anna. So once we go from tabletop, the next position we go to is claw fist. So it looks like you're making a bear claw. From bear claw, we're going to make a fist. And with fist, we're going to cross the thumb across the fingers to make a true fist, not tucking it in. So cross across. So fist. Then we go to in and out. Some of you are going, that sounds like a really good idea, Mr. McKeever. In and out, you open the hand way up and you make a waving motion. From there, the last step is opposition to all fingers. What that is doing while you're doing that is gliding all of these tendons on both sides of your hands. So again, we start here, thumb kind of looking like that. Step 2, tabletop, thumb comes out to the side, hand forms like this. This is a lumbrical position. From here, bear claw. And I don't know if you saw that, but I had a delay in my thumb moving, which is probably a motor problem. From bear claw, fist. Right, from fist to open close. From open close to opposition to all fingers. And from that, you're gliding your tendons. Some of you may have done that and they may actually feel really good in your hand. Because what you're doing is loosening up any kind of adhesions that are along all of your tendons. And that kind of stretches out the tendons all the way out to the DIPs. It is quite challenging, right? I did that specifically on my left hand because here I can do this on this hand pretty easy, right?
Mr. McKeever, when you're having your patient do that, do you do that at that speed so that they're kind of holding each position a little bit?
I do to start, yeah. So to start, we're going to do it nice and slow. So we're going to start, you go, okay, ideally when you're on tabletop, you want the thumb to stay as far out as you can get it. Yes. Because you want to kind of get that abduction of the thumb. Does that make sense? I know they have it here. And again, that's one difference I learned in my 6-pack versus the 6-pack this picture's out of the book. So the one thing, and the reason why I learned to get it out to the side, because we start here and kind of cross, almost like a flexed and opposed position. And the reason why I learned that when we come here and it goes out to the side is because that way you get full extension and full kind of abduction going on. But again, if somebody teaches you at your clinic a little different, it's a little different. It doesn't really hurt. But yeah, so we're going to start with just kind of like, okay, so we're going to do this now. So we're going to start here, 3, 2, 1. Now we're going to come here, 3, 2, 1, claw, 3, 2, 1, fist, 3, 2, 1, open, 3, 2, I can't get my thumb to move with it. There we go. 3, 2, 1, opposition, 3, 2, 1, back to here. And then eventually, like Riley asked, eventually we want to move it to a smooth motion where they're going through it pretty quickly and not sloppily, mind you, but it is a passive range of motion. So they want to kind of move through it quickly because again, the more smoothly they move through it, the more those tendons are gliding. And it's going to take some time, right? That's a complicated set of movements, right? And Anna said hers is quite stiff, right? And it kind of amazes. If you've got any family members like Brooke, your sister who does a lot of her hand stuff, this is called the 6-pack. Because think about it. So 1, 2, 3, 4, 5, 6. And I can guarantee you, if you guys know this by next semester, Dr. Ovreskin will be really impressed with you because she is a big proponent of the 6-pack. She loves this tendon glide activity. And for me, you know what I found as a PTA, I would do this. When do you think I would do that? Because I did this very regularly in the clinic for myself. When do you think I did this?
After manual therapy.
There, yeah, Diana's exactly right. After manual therapy. Because after I've done 40 minutes of massage, man, my hands just ache because I'm old. And autogenic encoding as well, absolutely, Anthony. When I'm playing here at home, definitely. I usually do set it on each hand between, like if I'm doing PvP where I'm actually playing against player, I usually do a set between each match just to kind of loosen up my fingers. And I'm getting a lot of gamers now to do that. And what we're finding is it actually improves accuracy and function of the hands. And it's a skill, right? It's like anything else. But yeah, definitely when I'm doing manual, especially if I'm doing suboccipital release where my fingers are constantly in this position here for like 20 minutes, it definitely helps loosen up my fingers. We can do other things. We can do active forearm exercises, elbow, shoulder exercises in that period of maximum protection in order to strengthen the associated musculature. When we get down to the moderate and minimal protection phases, we're going to start mobilizing the scar. So we need to get moving because the scar is going to be kind of right here. So we need to get moving that scar around. Sometimes it's horizontal, sometimes it's vertical, depending upon the doc's approach. Get that scar mobilizing. Progressive neuromobilization. So we got to get that nerve kind of mobilized in its sheath in the hand. Maybe doing some of those glides, right? Where we glide that nerve in the spot. Isometric strengthening should start about 4 weeks after exercise. One of the best isometric strengths you can give them is, guess what? Little ball squeezes, right? How do I reverse this and make it so I can isometrically strengthen the fingers in extension? If ball squeezes lets me do this, what could I use to get isometric of the fingers going out? Does anyone have an idea?
Rubber bands?
Yes. Yeah, both those, right? So anything that kind of puts around the fingers here that allows me to kind of go out. I've used string if I didn't have anything, right? I don't have any rubber. Believe it or not, I was looking around my house. I don't have any rubber bands in my house, which is hilarious. But for me, one of the things I used before in patients, something just simply as this, was just basically a little zip tie, right? I can put that, oh, I got it backwards. I can put that around their fingers and have them work on opposition, extension. I can put my thumb in there and really work kind of extension of the fingers. There's really limits to what they're doing. The hardest for me is going all the way to the fist. Yeah, you should get a ball to squeeze. I I have my whole collection. I don't know if you've ever noticed that while I'm teaching, but I'm constantly changing up when I'm working my left hand. I'll go to that, and I'll go to my little brain, and then I have my hard one here. So I work a little bit of everything, and if I really want to be challenging, I work a little dexterity with both of them, so I'm moving around. But I'm constantly doing stuff with this left hand just because sometimes it gets really irritated. Progress to pinch strength, okay? So let's talk about pinching. If you ever saw the commercial for the original Honda Element, you know all about pinching. Did anyone ever see those commercials? With the crab? I pinch, maybe just a little pinch. It's a great commercial. Makes me laugh every time. Okay, so I'm dating myself great. All right, let's talk pinching. What do you think we call this pinch here? And we're taking this a little beyond what's here, but okay. Delicate, okay. Then finger thumb up position.
Fine.
Opposition.
Fine. Okay. Here's a hint on pinching. It's usually named for the number of points touching. So guess what this gets called?
2-point pinch.
2-point pinch. Yep. Okay. 2 points. Because I have 2 fingers, right? It's really hard to do one. You can do a 1-point pinch like this. So like if I was putting something here, that's really a 1-point pinch because I've only got 1 thumb moving. But 2-point, right? Pinch. What do you think this is?
3 points.
3, right? 5 points to the Italian pinch. I love it. Right? We can do 3. We can do 4-point. It's really hard to do kind of 5-point pinch. Doesn't work out that well. That's more like lightning was kind of scary. Hopefully I don't lose my internet too. So 2-point, 3-point, 4-point. We can go to kind of 5-point. That doesn't work out well. That's more like sock puppet pinch. All right. So remember I said this is called 1-point pinch. This does have another term. The other term for this is called lateral apprehension. I don't know why. Don't ask me why. It's a hand therapy thing. But we'll actually do a test with patients that have median nerve injuries, scissors pinch, right? Where we have them laterally apprehend the piece of paper, and then we pull it. And the goal should be they should not be able to do that. So you saw that with my left hand. Now if I do it with my right hand, I can't pull that out. My left hand, for pretty easy, whoops, if I don't lose grip, it pops out. And notice, actually, I tried to cheat by squeezing my whole hand. So that's lateral apprehension grip. There is a weird grip. And again, this is beyond this lesson here, but if you learn these a little bit, for those who, because some of you had some hand therapy stuff on your list. Does anybody know what this grip is called? It has a really easy term. What am I holding? Pencil grip, good, right? There is a term for this, which is really kind of funny. This is called 3-jaw chuck grip. Sure. I usually call this the pencil grip, right? Or pen grip or whatever, right? Unless you're left-handed and then, you know, you have a weird grip. Shout out to all my left-handies in here, like me. So those are kind of grip stuff we can work on, right? And then or pinch stuff, and then with grip stuff, we can work again, doing motions like this. We can get out the putties and start working on different strength of putties. And we also have to desensitize, because when they have had surgery here, it really gets irritated. So has anyone seen desensitization exercises before? Maybe those of you that are techs. What do? Give me some hints. Okay, we start with some rice, good. Some beans, right? We usually start with something nice and soft, right? We start with something nice and soft, get it kind of desensitized there. And then what you can't see on this is this thing has some Velcro on it. So I might take some Velcro, a little bit rougher, and desensitize it, right? I might take something spiky like this ball and work desensitization. Or some of you may have noticed when I have my little massage star technique out here, I can work on some desensitization where I kind of do point desensitization. So all of that can come into play when we're kind of working on calming down those nerves. So it's after surgery, yeah. Well, I mean, so Brooke, if we have a nerve that gets really flared up and they get sensitization issues because of that, we could still do desensitization on them. But when they get really that bad, they're probably going in for surgery anyway. I hate to say it, if they get bad enough they need desensitization pre-surgery, they're probably going in for surgery. It wouldn't hurt to start it early, right? That we know from experience that if we start exercises early, it's easier in the long term, right? So it wouldn't hurt to start early with them. All right, ulnar nerve. If we can irritate that median nerve, that means we can also irritate the ulnar nerve. There are two spots of irritation for the ulnar nerve. There is the cubital tunnel, which is also known as what?
Elbow.
Elbow, okay.
Heel epicondyl.
Okay, good. What's the colloquial term for it?
The funny bone.
The funny bone. There we go. That's what I was looking for. That's that area that you smack that isn't so funny. What you're doing at that point is racking off that ulnar nerve. And have any of you smacked it so hard that your pinky's gone numb? Yeah, right? That's ulnar nerve compression and burns, right? That's ulnar nerve compression. So back here at that ulnar nerve, that medial epicondyle area, right? So again, looking at, we got the picture here. Let me clear off my old drawings. I didn't realize they stayed. It's kind of funny up there. So we got that ulnar nerve passing through here and it goes out to the pinky, right? So back here at that cubital tunnel. The other place it can get compressed is the canal of Guillain, or Guillin's canal. It's in the prehand, or the hind hand, if you want to call it that, for the foot. Does anyone know where that's at? The canal of Guillain? So let's think logically. What side is my ulnar nerve on? I'm giving you a hint.
I'm guessing it's somewhere in your wrist as it goes down to your pinky.
Yeah. So right here, what two bones sit out here that have points? Going back to anatomy. The P and the H. There we go. Hamate and the pisiform, right? So go down to your hand there and find those 2 points. Can you feel those two? And then kind of push in between them. Does anyone get a little irritated doing that? Not feel comfortable? Right. And then we do have a weird kind of anonymous thing where the nerve will pass out here as well. So there's a couple different places it can pass, right? So we're going to look at the same thing. So it's out here. Well, so the nerve can pass 2 different places. There's a blood vessel that passes too. So it can pass either between the hamate and the pisiform, or it can pass just lateral to the hamate. So either of those places, depending upon your anatomical kind of variance. But either of those are where we're going to bang and do that Snell sign again, where we tap, 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 tap. Ooh, again, a zing. I'm not supposed to zing. I'm supposed to have no feeling. So I keep using that hand. So we're going to do check for atrophy of this hypothenar eminence. Does this, and when we see atrophy, and I don't know if you can see it, but if I put my palms, let me stand up so I can put my palms up here. Can you see the thickness difference between my left and my right kind of thenar eminence here, my thumbs? How my right is nice and beefy, but my left is kind of, you can almost see all the blood vessels in it. The left is actually a little swollen today. Yeah, but you can see all the blood vessels and kind of in this, whereas you don't see them as much over here. It's because this side is a lot smaller in muscle mass, because this is my weak hand. This is my weak hand. So with median nerve, we get atrophy here. With ulnar nerve, we get atrophy here. We're also going to look for a positive Snell sign where we tap it. And they can also end up with what's called claw hand. where the hand kind of looks like this. That's where that nerve has atrophied so much that we start contracting. Again, just like everything else, we've got to clear it the whole way down, right? So often they'll get pain and paresthesia along the ulnar side of the palm, the 4th and 5th digits. Some patients will get it on this ring finger if they've got a weird nerve distribution. Progressive weakness, restricted mobility in the flexor carpi ulnaris and extensor carpi ulnaris, so they won't be able to flex on that side or deviate to that ulnar side. And they often end up with adhesions along the way. So they'll end up with weak grip strength, fatigue in the hand. Well, the good news is with ulnar nerve compression, we basically follow the same protocol for our CTS. We modify the provoking activity, right? A lot of people get ulnar problems sleeping with their elbow like this. When they sleep on their elbow here, where that ulnar nerve is now stretched out to its max. Or I've seen some people that sleep like this. Now think of how long my ulnar nerve is at this point, right? It's stretched out as far as it possibly can be stretched out. And so then it goes numb. And you wake up and you're like, man, I can't feel anything. I get that's the one I get the most holding a controller, because I grip so hard down here with this part of my hand. I get it on my right side only, I think, because I lose a little bit of strength over here on the left. So when I'm gripping a controller, I'm kind of death gripping it on my right side to keep control of it. And I get numbness and tingling in this hand because of it. They can do surgical release at either the canal of Guillain or back here at the cubital tunnel if needed. But just like everything else, we do surgical release. It can be problematic. CPRS, we talked about it briefly. We're going to talk about it again. Complex regional pain syndrome is where, again, because CPRS primarily develops in the upper extremities because of the nerves. CPRS1 is RSD, or reflex sympathy disorder, and CPRS2 is typically called causalgia. Remember, CPRS1 is not a nerve injury, typically. So CPRS1 is not a direct, not direct nerve insult. So I may have some other problem. I may have had a stroke. I may have had a fracture of the bicep. I may have had something to that effect that leads me to getting a weird nerve distribution pain. Versus CPRS2, which is a nerve injury. So it starts off with a nerve injury. So I may start off with carpal tunnel syndrome that develops into CPRS. They can develop a specific type of CPRS after a stroke called shoulder-hand syndrome, where the hand and the shoulder are the only two parts really affected. Sudex atrophy is part of CPRS1. This is where an injury to something else like a bicep or a bone or something like that causes massive and just complete sympathetic overload. So you literally just get pain and burning going down that whole arm, and it just causes that burning. So you stop using that arm. As soon as you stop using that arm, you get massive atrophy immediately. I tried to get a picture. There's a patient that I had seen back in Pennsylvania that had Sudex atrophy. Literally, her left hand that she had Sudex atrophy in looked like a kid's hand. It had wasted down that small. It was kind of crazy, and it developed in like 9 months. And it was all because she had a fracture of the clavicle. And when that clavicle fractured, it kind of went down in and dug into some blood vessels there. And that caused her to get CPRS of that arm. You can get a reflex neurovascular dystrophy where the nerves that innervate the blood vessels actually get damaged. Traumatic vasospasm, where the blood vessels actually spasm because of it. Usually with CPRS, the symptoms are more distal than proximal, and they progress in intensity, meaning that it starts maybe out here at the hand, and then it moves to the wrist, and then it moves to the forearm, and then it moves to the elbow. And eventually it will become the whole arm. And the symptoms will vary with time. This is why this is such a challenging disorder. But let me just take this back a step. If I have CPRS1 and the injury is somewhere else, either in my neck, my shoulder, my arm, and I don't treat that injury. Maybe I didn't know. Maybe I have a small like green stick fracture of the arm or something to that effect that I don't know I have. And they're coming to us because they have CPRS now. Is treating CPRS ever going to get better if we don't find out what caused it?
No.
No. Yeah. Right. And that is really challenging for hand therapists because they're like, man, I'm chasing this CPRS down this rabbit hole. And so then like 6 months later, they're like, let's get an MRI of the shoulder. And they get an MRI of the shoulder and they find out that they've got a piece of the acromion that broke off. And that's what's been causing the problem the whole time. And they didn't know that. They didn't have that piece of the puzzle. So they've been treating the CPRS and trying to calm down the nerves. But every time they move that shoulder, that piece of the bone is irritating crap. It is similar to peripheral pain, but peripheral pain itself is typically from so peripheralization of pain is typically from a nerve in the neck or the plexus in the neck. This is just idiopathic, meaning it literally can occur from anything. And this is what makes CPRS such a hard disease to understand. What I want you to get out of this is knowing that it exists and knowing that if you encounter this, if you encounter this in your clinic, it's going to be a challenge. So the etiology and symptoms we kind of already covered a little bit. The main thing here is a lot of these patients are eventually going to end up on disability if we don't get it better. Because I'm not joking that CPRS, when it progresses fast and it progresses insidiously, meaning it gets worse really quick and gets very worse really quick. This is why when they're seeing a therapist, if the therapist can identify that the patient has CPRS immediately, it makes for a better prognosis in the long term. If we're chasing other rabbits the whole time and we don't realize it's CPRS, then we end up with some bigger problems. We can end up with some gait abnormalities at the lower extremities involved as well. So this is kind of the book's interventions of CPRS. So obviously control the edema, correct sensory motor impairment, all this fun stuff. And then we have the chronic phases. I'm not going to read through all of that. The main thing to understand here is it has 3 clinical stages, whether it's CPRS1, CPRS2, or CPRS-NOS, which means we don't know what's causing it. We have the acute and reversible stage. If we can catch it early enough, we can actually make it better. Stage 2 is dystrophic and the vasoconstrictive phase. At this point, the nerve problem starts affecting the vascular system and it starts causing dystrophy, starts causing muscles to either waste, get hypertrophic, just kind of go wonkers in the arm is the best way of putting it. And when we have an ischemic problem, that's also going to cause some cell death, right? So we have stage 2, which is that dystrophic phase. And then ultimately we have stage 3, which is the long-term phase. If we get there, typically the they don't lose their arm, but they're going to have lifelong symptoms of CPRS and lifelong problems to deal with. We can do tendon glide exercises with them, the 6-pack exercises we showed. There are also different other types of tendon glide exercises Dr. Reskin will go over with you. Aquatic therapy is really useful for these patients because the pressure of the water on the arm seems to do a lot in relieving some of that sensation. We talked about graded motor imagery and mirror box therapy already, so I'm not going to cover that. Desensitization, we do want to improve. The one thing that a lot of therapists miss, and even hand therapists, is this one right here, which is total body circulation. Meaning the person needs to do some cardio workout. What is the easiest form of cardio workout we can have a patient do? Well, walking. They should be walking on a daily basis. 15 minutes of walking a day is really good for patients that have CPRS because it gets the heart rate up a little bit and gets the blood flowing. And when the blood flows, it's really hard for an area to be ischemic if the blood's flowing freely. And the main idea with patient education is to teach them they need to use that limb because eventually they will get what's called neglect. Does anyone know what neglect means?
Like left out, basically?
Yeah, right? If your friend neglects you and goes down to the opening of the casino, you might be really upset, right? That means they left you out of it. Well, neglect in the human body, when I get neglect, I literally start ignoring a limb. To the point that you could actually lift my arm up and point it and put it in front of me, and I'll say, that's not my hand. Think about the psychological things that go on to that. Like, to me, that's crazy that you could literally move their hand up and they can see it's attached to their body, and they're like, nope, not my hand. What? Right? So when they get to that point, we've got some serious problems, right? Because at that point, the brain has turned off all transmissions to this arm at that point. So we got to get them to avoid the fear of using it.
Mr. McKeever, before you move on, I had a question from stage 2.
Certainly. Yep.
You said dystrophic, and you said muscle waste, or it can go hypertrophic. So
Yep.
it's kind of either or.
Right. And it could be like, you could have something where maybe the, and like, for example, because I was talking to a bunch of hand therapists yesterday about this, because I want to make sure I was kind of clear on this, because this is something even I don't fully understand, to be 100% honest. The one therapist told me that they had one where all of the, so again, think about your hand. Which side is your flexor side and which side is your extensor side, right? Extensor side is medial or lateral. Feel it if you don't remember. Okay, good. Extensor side is medial, flexor side is kind of lateral, right? You can feel that over there. You've got some crossover as well, right? Where things go over. The patient had all of the flexors and extensors of the hand waste away. They got complete atrophy. And for some reason, brachioradialis got hypertrophied and just became like this honking big muscle there, right? That's such a weird presentation. And so what ended up happening is, because that muscle had hypertrophied so much, the patient ended up with kind of like a flexed arm position where it was radially deviated. And they had to fight the spasticity of that brachioradialis, right? So yeah, it could do either. Dystrophic just means weird changes in the muscle tension length function, if that makes sense. That help clear it up, Riley? Cool. All right, let's talk about some fun hand injuries here real quick before we move on. And again, at this point, what I want you to, before you freak out, because I can see Brooke freaking out because there's like 2 pages here. All I want you to know is the definition. You don't have to be able to identify it by picture. You just have to know the definition for right now. Dr. Vreskin is going to go over the specifics of them. Okay? Definition. Nothing else. Are we okay on that? Definition, nothing else. Can I get somebody to say yes?
So would this be back like on the boards?
This would be on the boards. That's why I'm hitting the definition so early. Yes.
Okay, thank you.
Right? So carpal tunnel syndrome, we know median nerve, right? What you need to know for that. Dequervains, inflammation of EPB. What does EPB stand for?
Extensor polybrevis.
Good. And what does APB, PL stand for?
Adductor postus longus.
There you go. Good, right? Oh, look, going back to anatomy here. So it's basically inflammation of this side of the thumb. Does that make sense? So dequervains, a lot of times, again, they'll get pain out here from doing stuff with that hand. Again, common gamer condition, right? Because if I'm going like this constantly pressing buttons, or more importantly, since we've gone to controllers like this, where not only do these sticks go around in circles, but now what else do? They go down. There's a third trigger in there. So when I'm using that and I'm moving them around, I mean, you can just see the muscles out there in my thumb kind of freaking out. And so it's really common for gamers to get that way, or people that knit and stuff like that. So dequervains is there. A Colles and a Smith fracture are the opposite of each other. So a Colles fracture, and Colles goes along with scapuloid. So let me get my little drawer here. So Colles, but not, I think that was not the way I want to draw it. Colles goes along with scapuloid here. They kind of go hand in hand. Fouche, right? Falling outstretched hands. Scapuloid gets fractured. It gets pushed back into my radius, and the radius displaces posteriorly. So it goes out the back side of my wrist. That is a Colles. A Smith's is an anterior dislocation of the radius or ulna. Does that make sense? So posterior, Colles, Smith's, anterior. That's all you have to know about that. We don't have to talk about the method of injury and anything like that. It's just that a Colles is posterior fracture, Smith's anterior. And the scaphoid goes kind of along with Colles. Then we have a boxer's fracture. Has anyone seen anybody get this before? Boxer's fracture is a kind of a misnomer because a boxer is supposed to punch with those two knuckles there, right? A boxer's fracture is when somebody comes in and instead of hitting with those two knuckles, ends up hitting out here. It hits with the pinky knuckle, right? It's usually from a poorly thrown punch or somebody dodged you. I had it once when I was training in a bat on a heavy bag, and I was training and the bag was one of those moving bags. And when I went through, the bag moved, and I was too close to the wall behind it and slammed right into the wall in that pinky knuckle. Felt great. So Colles posterior, Smith's anterior, scaphoid fracture, boxer's fracture. Are we good so far?
Yes.
Yes, Diana's like, I think, maybe?
Yeah, I got it.
Then we end up with Dupatrin's contracture. And this is funny because there's been a lot of ads on this with John Elway lately. Dupatrin's is typically a contracture of the 4th and 5th digit, so out here, at the MCP, so metacarpal phalangeal, and proximal interphalangeal joint. So it is a contracture of the kind of the tissue in that area. And it kind of gets this nodule-like look on it. Does anyone know? So with the physical therapy used to be the only treatment for this or surgery. Why do you think there's an ad for it now? Why do you think John always advertised? Yeah, that's it, John. Drugs. There's drugs for it now. Right? They're starting to use stuff like Botox in that area. So, you know, factsonhands.com. So Dupatrin's is out here. Now, that doesn't mean that you can't get a Dupatrin's elsewhere, but typically Dupatrin's is out here. It does happen quite frequently in professional quarterbacks. Why do you think that is? I mean, like he had it, what's his name? The guy, Johnny Unitas had it really bad. Yeah, follow through, right? Think of the way I hold the football. Right, when I'm holding the football like that, that kind of leads me to getting a contracture like that. Claw hand deformity, again, claw hand. When you see claw hand, I want you to think ulnar nerve. Claw hand, ulnar nerve. Claw hand, ulnar nerve. It looks like a Dupatrin's, but it's not because of the soft tissue now. It's because the nerve. And the fingers kind of claw up. Benediction hand is also known as preacher's hand. Does anyone know what benediction is? Any Catholic in here or Lutheran?
I guess Saint Benedict.
Yes, from Saint Benedict, right? That's may the Lord keep you and bless you. May the Lord make his face to shine down upon you and give you peace. Yes, Catholic school taught me something, right? So it's a median nerve paralysis. It's seen when you make a fist and the 4th and 5th fingers move, but the 2nd and 3rd don't. So when the priest gives you benediction, his hand is often like this, right? So I'm making a fist, these fingers move, these kind of stay paralyzed. Ex Benedict, I love it. Well, I guess you can mix up Ex Benedict with this. So when you think of benediction or ape hand, which are often confused together, I want you to think median nerve. I'm trying to give you a way to remember these for the boards. Does that make sense? So if I say claw hand, you say?
Ulnar
Ulnar
nerve.
nerve.
Right, I say benediction or ape hand, you say?
Median nerve.
Median nerve, there you go, good. Right? So the only difference between benediction hand and an ape hand is in benediction hand, when I go to make a fist, these fingers don't go along with me. In ape hand, it's the reverse of claw hand. In this case, these fingers contract up like that. And it looks like I'm kind of holding a banana or something like that. That's why it's called ape hand. And usually you can't use your thumb muscles in the inside of your hand as well. So claw hand, ulnar, benediction, ape, median. It just depends upon the way that median nerve paralysis happens. Boutonniere's is a central tendon extensor hood rupture or slip. Wow, that's a lot. What does that tell you? What side of the finger is it happening on? The posterior side or the anterior side? Or maybe I should say the dorsal side or the palmar side.
Posterior.
Yes,
Maybe the
posterior,
dorsal?
right? Yeah, right, because extensor hoods are going to be back here. When you have a Boutonniere's deformity, the MCP, right, so metacarpophalangeal, is going to extend. The PIP is going to flex. The DIP is going to extend. So it's going to look like that. That is a Boutonniere's deformity. And if you ask me why it's called a Boutonniere's deformity, I did not go to school to learn that. I just have learned what it is. So Boutonniere's, extension, flexion, extension. Extension, flexion, extension. Swan neck. Swan neck is MCP flexion. So swan neck is MCP flexion, PIP flexion, DIP extension. So swan neck, my finger looks like this. Why do you think they call that swan neck?
Looks like a swan.
Yeah, it looks like a swan. Yeah. Absolutely. Kids with MD can definitely have these deformities, Diane, for sure. So can people with all kinds of other hand issues like RSD. So CRPS 1 and CRPS 2 can lead to these deformities as well. These are kind of some of those. Parkinson's could. Yep. Parkinson's, I usually see Boutonniere's. The other thing, the Boutonniere's deformity, you can get if you're one of those people that laterally crack your knuckles. I don't know if I'm calling anyone out on that in here. I'm calling myself out on that. Yeah, John's like, uh-oh, right? Anyone do one of these numbers when you crack your knuckles? Yeah, just did it, right? I always get yelled at for laterally cracking my knuckles. Dr. Ovreskin screams at me about it sometimes. All right, so Boutonniere's, extension, flexion, extension. So extension, flexion, extension. Swan, flexion, flexion, extension. And yes, you will have to actually know the difference between these on your boards. That's why I'm covering them now. Mallet finger is a rupture of the extension tendon at the DIP. So a mallet finger just means that that DIP, it's the only thing, it's kind of stuck down like that. It makes like a hammer. That's it. Boutonniere's can develop from RA, but remember, when we have RA, a lot of times we have other structural changes as well. So we've got those kind of nodules in the back of the hand. But yeah, it could look like RA. Gamekeeper's thumb, also known as skier's thumb or breakdancer's thumb. That's a rupture of the ulnar collateral ligament of the thumb. And so that's where the thumb goes backwards. Right, so they land down, right? And the thumb, let me bring this out here a little bit if I can get some extension range on my little thing here. So I land down and my thumb goes backwards. It happens quite frequently. So Cindy asked, does cracking your knuckles actually speed up arthritis? The jury's still out on that. Is that to speed up arthritis, or is that you're already predisposed to arthritis, Cindy? That makes sense. Maybe.
Wasn't there a doctor who cracked only one hand his whole life and like didn't do the other one and nothing happened?
That sounds pretty plausible, honestly. That's possible. If you find that link, I'd like be interested in it. But honestly, what we find a lot of times is people so the people that crack their knuckles typically work more with their hands anyway, Sydney. So is it that you're cracking your knuckles caused your arthritis, or is it all the work with your hands that caused it? Right? So I don't know. The jury is out. There are plenty of people that say it does, and there are plenty of people, just like there are people that say you crack your neck and it develops arthritis in your neck. Well, probably not, but you can actually die from cracking your neck, just to let you know. We'll talk about that in neuro. You can actually have a stroke from cracking your neck. Yeah, it pinches. Oh, great, I do that too. It pinches off your vertebral arteries sometimes. Anyway, after that beautiful thought. So gamekeeper's thumb going up. It also, that gamekeeper's thumb's named for soccer players, because think about the way soccer players try to catch the ball, right? And I don't know if you ever have seen somebody stop a ball or kick those soccer balls. They come pretty hell in. It's not like they're slow. They're moving at a pace. Trigger finger. It causes, so trigger finger is, and I always get asked this, is trigger finger like Dupatrin's contraction of the other fingers? Because trigger finger is typically these two fingers, right? If you're pew, 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 that's trigger finger, right? Not really, because Dupatrin's is a congenital problem that happens with the soft tissue of those fingers, whereas trigger finger is just an overuse problem. And with Dupatrin's, if you try to straighten these fingers out, they will not straighten. With trigger finger, if I've got here and you work on them and you push, they'll snap straight and they'll stay straight. And then eventually they'll kind of contract back, but then you push them again, they pop out straight. I had a guy that had trigger finger really bad of his middle finger, and he used to drive down the road snapping his finger out, and he'd be like, people always gave me a weird look because I kept giving him the middle finger. I kept telling him I was just doing my therapy. That didn't get a laugh from anybody. Sad. Okay, so John, that actually was his thing. All right, so here's some pictures of it. So with, I'm gonna use that now, right?
Mr.
Yes.
Receiver,
Yep.
a little side question. Why would your fingers get locked? Like,
So you mean as far as one of the conditions I discussed, or something different?
yeah, like would that be like one of the conditions? Like sometimes my fingers, when I'm like doing anything, they get like, they just lock in for
They
some
kind of
reason.
get stuck like this.
Yeah, they get stuck.
All that is just that the fascia of your hand just decides I'm not going to move at that given moment. A lot of times it's maybe you have some adhesions in your hand. That try doing those tendon glides, see if it stops happening less. Because I bet it's probably your tendons are just kind of getting stuck up, or stuck in extension. Yeah, I get stuck that way when I get stuck this way when I do what do you call it? Suboccipital release. And there's many reasons. It could be nerve. It could be, I often think it's more soft tissue than we try to give nerve credit for. So Truman asked, do people with trigger finger have voluntary contractions? Absolutely. They can still contract their thumb. They can flex it. When they go into extension, a lot of times what you'll see is they're trying to force it into extension, and then it pops. And then later on, it's back to here again. So like I said, it's more of a lot of times it's kind of these, so there are bands in through the palm here that are your basically your pulley system of your palm that go along the flexor tendons. A lot of times it's more of those pulley systems. Like if I come down here and I find my pulley right here, I can cause that finger to flex without actually, they can't extend without assistance or extreme kind of fighting it, if that makes sense, John. So they've really got to kind of work and like, okay, I'm going to extend. And what you see is when they extend, it pops. And what that is I'm holding it, right? So if I'm holding this, I know that's where one of my tendons is right there, one of my pulley systems. If I'm holding that and I push down, I am fighting to extend that finger, but I just can't do it. And now what if that finger just decides to pop loose? It kind of snaps out. Does that make sense? What I said is a lot of people think it's Dupatrin's, the opposite of Dupatrin's. But in reality, Dupatrin's is a congenital soft tissue disorder. You could almost think of Dupatrin's, and a lot of people are starting to think of Dupatrin's as more of a autoimmune disorder that just affects the hands. Whereas trigger finger is more of an overuse syndrome. A lot of cooks will get trigger fingers. I don't want to say cooks, I guess I should say chefs too. I had a chef from downtown at what's the really big Ruth Chris Steakhouse that had that problem. He had really bad trigger finger in his left hand. It was from a lot of fine chopping. Like he held the knife. When he held a knife really weird. Where's my, I don't know what happened to my pencil here. But when he held a knife, he held the knife with just these two fingers. And that was how he did all his chopping. And so he ended up getting a contracture of fingers from holding it that way. So ulnar nerve distribution out here, median nerve distribution here. But again, I told you, sometimes ulnar nerve comes all the way into this, and sometimes median nerve comes all the way out to here. Sometimes median nerve stops here. We all are a little bit structurally different. So there's a picture of what deep veins looks like, that extender of the thumb where the problem is inflammation back here. There's mallet finger, right? Looks kind of like that. Here's our fractures. So this could either be a Colles or Smith's, depending upon the way the bones get displaced. In this picture, it's a posterior dislocation. So that's a Colles. If those bones went that way, it's a Smith's. Oh, there's a Smith's. There we go. There's my boxer's fracture. There's my little scaphoid fracture. Yay. Scaphoid fracture, the only way that you can really treat it is let it heal. So here's a good image of a kind of really effective Dupatrin. So you can see how that soft tissue is binding up. Can't you see how tight that soft tissue is? That's a really good picture of a Dupatrin. And a lot of times that's what they look like. Literally, you can clearly see the tendons that are bound up. So here I have a swan neck, right? Kind of looks like a swan. All right, and there I've got, what's the other one that goes along swan neck? That looks opposite of swan neck, kind of. If you go to prom, you put on a Boutonniere. So that's a Boutonniere deformity. That's a boot. You really need to know what this contracture or this problem is a boot. I don't remember what I picked this picture up of. I think this is partial trigger finger, but I don't remember. That was one of my patients, and I can't remember why I put that in here. Gamekeeper's thumb is where you get a separation, typically there. And here, with this handout here, we are going to have to figure out, by testing this patient, is this a claw hand and it's a problem with the ulnar nerve, or is this benediction hand and it's a problem with the median nerve? And we'd have to do myotome testing. You're exactly right, myotome and dermatome testing. Very good, Diana. You're in the associative phase a little bit there. And we would do it bilaterally, yeah, because we want to see if they've got a problem. And a lot of times what I find is most people that have soft tissue contractions like Dupatrins and that have it bilaterally if I test them. But again, that's just kind of anecdotal. That's not research based. That's it on the hand. Did that fry anyone thinking about all that? Yeah.
Not yet.
Not yet. Again, with all those definitions at the end, I don't want you to be able to identify them by picture. What I want you to be able to do is just define them. Right? So if I say breakdancer's thumb, you know that the person probably fell and forced their thumb back, right? If I say, you know, somebody that's got deeper veins, you know it's from overuse of the thumb. Bianca asked, so all these, do we see a lot of these injuries? Actually, yeah, believe it or not, Bianca, I did. I know they do tend to see OT, but what I'm finding of late with OT is getting a lot more involved with dealing with patients kind of functional around the house, going and seeing patients at home, doing a little bit more workers' comp type stuff, and less about these general orthopedic type stuff. OTA is also ending up, I'm seeing a lot, there's a lot of opportunity right now in OTA and working in like domestic violence shelters and women's shelters. Because a lot of times when you have people that have been in that type of abuse, because OTA also has a little bit more background in psychology than we have, right? They actually take courses in psychology where you guys will just get basically Mr. McKeever's diarrhea of psychology one day, a real quick lecture on it. They actually have some basis in psychology. So they spend a lot more time in those type of situations. Do we want to break before we start PNF? Okay, so let's take, I'm gonna pause my recording. Okay, so we're back from break. We finished off with the kind of nerves and hand type stuff. So after nerves and hands, we're obviously gonna get into a very light topic here and talk about PNF. This is by far my favorite lecture to teach this semester. I can share that with you then. Hold on a second here, Ryan. Give me 1 second. I can share it. 1 second, 1 second, 1 second. I don't want to just send it to Bianca. There you go. All right. Anyway, so we're going to talk about PNF now. And PNF is by far my favorite thing because I love the way that PNF works. It amazes me. The first time I used this and it worked, it blew my mind. So before we get started with PNF, how many of you guys have heard of PNF before? I'm actually going to put my wrist brace back on. Those of you that may be in the clinic, have you heard of it? Only for MedTerm, okay. So if you've heard of it, probably the only thing you've heard of is the patterns. Would that be fair to say, John?
Yeah, pretty much.
Yep, okay. And we're gonna talk about it. If you ask most clinicians and you ask them what PNF is, that's what they know about PNF. But PNF is so much more. So we're gonna talk about a brief history, kind of look at the neurophysiological points of it, talk about some key points, and we're actually gonna talk about the motions and the patterns then. So we're gonna start it today. We are gonna finish this Tuesday and we're gonna do some of the motions on Tuesday together. So Tuesday's gonna be another kind of interactive working out kind of day. So PNF started with Dr. Herman Cabot, I just like his name, in the 1940s. It uses a hierarchical methodology. And what hierarchical methodology means, in case you don't understand it, is one technique builds on the next technique, builds on the next technique, builds on the next technique. How many of you guys have done some form of martial arts at some point in your past? Or dance? Dance is another example of this. Both? Okay. Right? When you were taught dance, did you directly go into doing, full-on ballet or even Oscar like boxing, exactly, right? And with the martial arts, did you automatically get into the jumping, spinning, twisting kicks? Right? Yeah, no, you build on the building blocks first. That is a hierarchical methodology, right? Oscar with boxing, right? You started with technique, right? And it's some endurance, because if you can't do that, you can never box, right? I mean, in case in point, look at Jake Paul. Anyway, moving on. I knew I could get you to laugh there. Or actually, more than Jake Paul, what was the guy that the other influencer that just boxed this weekend? Deji. Deji was bad. Influencers should not box. I'm just saying that right off the bat. Let's just go there. Anyway, save the boxing for the boxers. It is an endurance thing. Did you see the Deji fight, Oscar?
Yeah, I saw the highlight and I was just amazed of like how he was doing good, and then suddenly in the second round he just like stopped moving.
The best way to put it, he just done. Yeah. So yeah, definitely that's a hierarchical, right? You build up the endurance. When I was in the martial arts, I didn't start doing jumping, spinning kicks, and to this day, I'm not very good at jumping, spinning kicks. I understand how they're done. I'm just not good at them. So I stick with what I know. So it builds on techniques. That comes from Maslow. Do you guys remember a little bit about Maslow, maybe from Dr. Reskin's class? Or maybe, because I know she briefly talks about it, or maybe from a previous class in like high school.
Wasn't it like the hierarchy of needs?
There you go, the hierarchy of needs. Good, right? Maslow said, if you don't have these things, you can't have this. That's a hierarchical methodology. He worked with Maggie Knott and Dorothy Voss, and they worked with him to kind of develop the principles of PNF. Voss was also an OT, so she was PTOT that collaborated with him. What he observed when he was doing some observations, he was a research PT, so he wasn't just a or he's a research orthopedic doc, if I remember correctly. He observed that human motion and looking at the way they moved around. And he thought, well, okay, there has to be some neurological involvement, obviously, in movement, right? But before he kind of developed PNF, patients were rehabilitated using one motion, one joint, one muscle at a time. So when we started as rehabilitation aids way back with good old Mary, we usually started off just if the patient had a problem with the arm, we would work the bicep and we would work flexion. We would work the bicep and we'd work supination. We'd work the bicep and work shoulder flexion. And we just work one section at a time. Kabat went and studied a bunch of Eastern medicine practitioners, and specifically monks, in the way they rehabilitated. And what he found was they don't rehabilitate the same way we do. Specifically observed some Shaolin monks in the way they train. And what he found was, well, movement occurs in spiral directional patterns. We don't just move, right? When we're moving, we're doing all kinds of functional movements, right? And we're doing spirals, we're doing diagonals. Occasionally we might do straight up and downs, but it's pretty rare. He also, side note to that is he also noticed that the martial artists that tend towards rotational components and circular movements were able to get around better on training than they were the martial arts that were kind of linear and straight. And he's like, okay, there's got to be something to this. And what he really found out in the martial arts is those martial arts that were circular in nature and focused on movement and fluidity used natural patterns of movement, and it would stimulate the nervous system better. So he said, what if we do that to therapy? And so Kabat and Knott brought it in and said, well, let's try doing this in therapy and say that there are natural patterns of movement. And if we can stimulate our nervous system in a specific way, we could actually trigger a certain isolated injured muscle to actually work again. And back in those days, back in the 40s and 50s, he had a great population to test this on because at that point we were going through polio. And so it started with treating patients with polio. And then over time, PNF has continued to develop and change and means different things to different people. So some key terms. Well, PNF is proprioceptive. That's actually interesting. I might have to actually look it up. So Riley says that Frey Faust developed a whole contemporary dance form on that principle called the axis solos. I actually have to look that up. That's actually, I wonder how close the research was on those two. And if maybe one borrowed from the other, another borrowed from the other. It's actually kind of, I have to look that up. But well, it doesn't mean that he didn't base some of his research on it, right? You'd be amazed at how many people in dance theory actually base their stuff on physical therapy. Because it's not that far, I mean, it's not that far off. Same thing with martial arts. But anyway, PNF, proprioceptive, meaning referring to the stimuli aroused in an organism through the movement of tissues, where you are in space. Neuromuscular, pertaining to nerves and muscles. Facilitation, the hastening of a natural progress or process, making things easier, right? If I give you $1 million, right? If I come up to Oscar and say, here's $1 million, I have facilitated his ability to become a millionaire. I couldn't do that because I don't have $1 million, but if I would, that would facilitate his ability to become a millionaire. It would speed along his process, right? Versus doing the hard work. It's almost like we had a president that way. Anyway, so it combines a couple different movements. I'm going to keep moving. And I didn't say that. Chopping. Chopping is a combination of bilateral upper extremity asymmetrical patterns performed as a closed chain activity. Some of you in the clinic may have seen patients doing chopping motions and not realize that's really PNF. So chopping motions are a lot where you take your hands together and you have them move through motions where you're using one to facilitate motions of the other, right? Almost like you're chopping an axe. So we have chopping, we have developmental sequencing, right? The progression of fine motor skill acquisition, right? And we talked about this before. You have to be stable before you can become mobile, right? And then there are 2 stages after that, which we don't really often get to in physical therapy because usually we get the patient stable, we get them mobile, and we get them out. But when you think about it back to, again, those of you that did sports or martial arts or dance or whatever you did, boxing in Oscar's case, You started developing stability in your stance. Then you started getting able to move around, right? And then you had controlled mobility, meaning you could move around a lot better and controlling your body as you're doing it. And then eventually you develop skill, right? You knew when you had to move and when you didn't have to move. You knew what motion to do, right? So controlled mobility and skill are kind of the last two phases. Yeah, all of that comes into play. I will say that probably when I played way back when I played football, I never made it to skill. I didn't have skill. I had controlled mobility, but I wasn't that great at football, right? But I was, I learned through it. We had to do stability, we did mobility, and actually, I believe our coach believed in us. We worked a lot of stability drills in football. Mass movement patterns: the hip, the knee, the ankle, the shoulder, the elbow, the arm move into flexion and extension simultaneously, right? It happens naturally. Think about when you're talking, right? When you extend your elbow, your wrist often extends. So stuff happens in patterns. And you can promote or hasten the response of neuromuscular mechanism through stimulation of proprioception. That was what Voss said. So if we stimulate proprioception, I think I'll look at that then. We can stimulate and hasten response of neuromuscular mechanisms. It places specific demands on specific muscles in order to elicit a desired reaction. So there are some more key terms we have to get here. Some of these we've already covered. So we have agonist versus antagonist. Do those two terms look familiar? I think we covered those before, right? The agonist movement is the direction we are going. So if I am doing elbow flexion, that is my agonist movement. My agonist muscle is my bicep. The antagonist is the muscle or the stuff resisting motion. In case of elbow flexion, my triceps are resisting it because they would rather me go into extension. So that's my antagonist. And again, these are just definitions. We'll get into why they're important in a little bit. Approximation or compression. This is the compression of a joint surface by manual compression or weight bearing. When I'm sitting here on the chair, I am compressing my ischial tuberosities. In the process, I'm also compressing some of my muscles, and I'm putting that compression up through the discs of my spine. So there's compression going on, or approximation, bringing those joints closer together. Manual contacts are probably the biggest thing in PNF that are important. Manual contacts are how you touch the patient. And I think we can all agree, and we've learned it since we're in elementary school, there is good touching and there's bad touching, right? And we're not talking about that type of bad touching either. In PNF, there are techniques and directions where the way you should touch the patient and the way you shouldn't in order to facilitate them to move a specific way. If I put my hands in the wrong place, that can oftentimes mess up the flow of a patient's movement. So we have to learn how to slide and glide our hands in order to actually make the patient get the most out of their activities. And honestly, for those of you, and you can see the way I'm moving my hands, for those of you that had martial arts, there we go. Very similar to Tai Chi or very similar to martial arts movements. When we are doing PNF, we are basically dancing with the patient. So those of you that have done dance, this will come into play as well. We are moving to facilitate their best techniques so that they can go in the direction they need to go. We're also cueing them with our hand placement. So if I put my hand out at the distal hand, I'm kind of cueing them to come into my hand. I could also put pressure, which would cue them to come back in. So there are different type of manual contacts we will do in PNF. We also have manual cueing commands, right? This is where we tell them to do things, right? There is some proprioceptive feedback cueing that we give them in order to get them to do specific motor outputs. Maximal resistance is the greatest possible force that can be applied to a patient. When we do PNF in the clinic, I'm actually going to pick somebody and I'm going to give them maximum resistance. And what you guys will find is I don't have to do a lot of work to give a patient maximum resistance with PNF. It's not as tiring as if I'm literally putting all my force into blocking John into doing a sit-up or something like that. There are techniques in PNF because we're moving the diagonal that I can use my body instead of my muscles to resist him and provide him with effective resistance to strength training. Normal timing is a sequence of distal to proximal coordinated muscle contractions. So if you were reaching above head to grab something off a shelf, there is a normal timing to reaching up there. Have any of you ever woken up in the morning to get a cup of coffee or something like that, or to make tea, and you wake up and your body's just not quite awake yet, and maybe you reach up for the coffee or the tea and you grab a hold of it and suddenly it just falls out of the cabinet? Or maybe a cup does the same thing because you're just not quite awake. Or you've gotten something out of the fridge and you drop it, right? That's because your normal timing is off at that point. Your brain is not caught up to the rest of your body at that point because maybe you're a little sleepy. Sometimes it might happen when you're a little impaired, right? All of that has to do with normal timing. It also has to do when you go out with your friends on a Friday night and they're getting a little tanked and that buddy goes to sit down in a chair and his brain thinks the chair is in one place and the chair is actually in another, and poof, down he goes. That's a normal timing issue. The brain functioning with the nerves, functioning with the muscles through his timing off. We're going to talk about stress stimulus and stretch reflex. Specifically, I don't want to cover those right now, but they're just talking about different positions that we either lengthen or contract the muscle. Traction is the opposite of approximation, right? That's where we pull stuff apart. Verbal cueing, much like manual cueing your commands, right? Verbal is when we start talking, start giving them, right? If I tell Jason to stand up, I'm giving him a verbal cue. I can also tap him on the sides of his hips and give him a manual cue to stand up. So they kind of go in concert. Visual cueing, patient seeing stuff. And again, a lot of what we're going to do in PNF is making sure the patient sees themselves moving, because when we see ourselves moving, we can self-correct. Use a lot of mirrors in PNF. These three terms kind of go together. So we have irradiation, overflow, and successive induction. Irradiation is a theory that states energy is transferred from stronger muscles to weaker muscles in groups or patterns. Overflow is an activation of an involved extremity due to intense action of uninvolved muscles. So what these are saying is, if I have a problem with the biceps, I might be able to get the biceps to fire by firing my anterior delt. Or I might get the biceps to fire by firing off my forearm muscles, my forearm flexors. I'm using other muscles to trigger a cascade effect of firing off muscles. When I learned this in school, I did not believe that was a possible thing until I worked with a stroke patient and I saw it happen live. And I'm like, holy crap, Renee, who was my teacher at that time, is not joking. I guess I should call her Dr. Borromeo because, you know, Pima doesn't like us calling us people by first names. Dr. Borromeo was right. This works. Holy, lots of curse words. Successive induction is an increased response of an agonist as a result of a contraction of its antagonist. So I can get my biceps to fire maybe after firing my triceps, or I can get my triceps to fire after firing my biceps. That works on that reciprocal inhibition theory, which is the next word here. Facilitation of the agonist muscle. We also can cause autogenic inhibition, which is where we cause inhibition of muscles by stimulating the GTO. That kind of is where we're going to lead into some of this other stuff with the reflexes. There's a lot of theory here. Bear with me through it. It'll make sense when we get into the actual doing it. I can hear Diana right now going, her eyes are twirling around in circles. And
No, I'm actually thinking about the growth and development class.
yep. Guess what?
Right?
Growth and development follows a lot of these principles, doesn't it?
Yeah, that's why it's like clicking in my head. So
Yeah.
I'm actually paying attention.
Hey, wait, does that mean you normally don't? I'm just joking. I'm just joking. Don't answer that. All right. So when we started developing PNF and we developed the basis of this, Cabot built off of Charles Sherrington. And Charles Sherrington is often considered the father of physiology. Not physiotherapy, but physiology, the study of movement, right? Sherrington also built off a range of Descartes studies of action and reaction principles. But Sherrington had found a couple different things. He had found a myotatic reflex, or the Liddell-Sherrington reflex, which we're going to talk about. Tonic contraction of a muscle is a response to being stretched. Hold that thought for a second. We'll come back to it. The main thing Sherrington gave us was what's called Sherrington's second law. This was the law of reciprocal inhibition. When an agonist is contract, there's a simultaneous inhibition of the antagonist. When I contract my bicep, my tricep is inhibited to allow for normal movement. These other laws are not related to PNF, but they're interesting and may come up on your boards. And boards do like asking questions about Sherrington in the other category, because Sherrington is, again, kind of the father of movement here for us. One of his first laws stated, every posterior spinal nerve root supplies a particular area of the skin with overlapping dermatomes. Hey, you guys already learned Sherrington's first law, didn't you? You just didn't know it was called that. You learned the principle of dermatomes. Well, Sherrington was the one that said that. Sherrington said that when a posterior nerve exits the body, it supplies touch to a specific area. You know, right now, when I say that, you guys are like, well, duh, right? But back when Sherrington was around, that was groundbreaking, right? We used to think that, you know, a lot of things, we used to think that sensation was just kind of a weird offshoot of muscle function, but sensation is its own thing. He was also involved in stroke rehab and stuff like that, where he came up with the shift Sherrington reflex, the rigid extension of the upper extremities in response to damage to the spine, which is often accompanied by paradoxal respiration, where the chest gets paralyzed. So they breathe paradoxically. So basically what he showed was patients often get a rigid extension of the extremities during a spinal cord injury. And the reason they're doing that is to open up the chest so the patient can breathe a little bit easier when they're doing paradoxal breathing. This one I didn't learn by the Volpian Hindheim-Sherrington phenomenon, but I did learn this in school by using different techniques. It says there is a slow contraction of de-enervated skeletal muscles by stimulating the autonomic cholinergic fibers innervating its blood vessels. That's really complex, but what it's saying is, if we stimulate blood to flow, muscles can fire. That seems, again, very kind of duh here nowadays. But there was never, back in the day Sherrington was going through, there wasn't a connection made between blood flow and muscle function. So he's literally saying is, if we can increase blood flow to muscles, we could theoretically cause a muscle to fire, especially if it's had nerve damage in its past. Well, yeah, we increase blood flow to the area, it's going to increase overall healing of the muscle, it could fire. It may seem silly, but it's up. Out of all of these, the one you definitely need to know is this law of reciprocal inhibition. That by far is one of the board's favorite questions to ask you about, because they love reciprocal inhibition. So you need to know that like yesterday. His laws or his studies led us into the terms of myotatic and inverse myotatic reflex. This is a key feature of PNF, and this is a key feature of therapy, and you have to know these when we get into neuro next semester. So I'm going to give you my way of remembering these if you get a board question. So myotatic reflex has two words. It is also known as the stretch reflex, which has two words, which uses the muscle spindles, which has two words. The inverse myotatic, before we get into discussion of them, inverse myotatic has three words, also known as the Golgi tendon reflex, which has three words, also known as the GTO, or works with the GTO, the Golgi tendon organs, which has three words. This was important in studying this for me. That if the boards asked me a question about myotatic reflexes, I knew they were asking me a question about the muscle spindles. Versus if they asked me a question about the inverse myotatic reflex, they were asking me about the GTOs. Well, that's all fine and dandy, Mr. McKeever, but what does this all mean? A myotatic reflex, when an agonist muscle is stretched or when a muscle is lengthened, a stretch reflex causes that muscle to contract to resist the stretching. It is a protection method. So, what that's saying is, if for whatever reason I'm stretching out my biceps here, and my biceps, I don't want to hold weight because that's going to add to the other one. And I'm stretching my biceps, and I stretch my biceps so far that those muscle spindles start getting worried about the stretch and say, if you keep stretching me, the muscle body is going to get damaged. The stretch reflex kicks in and says, okay, I'm not going to stretch anymore. I'm going to force the muscle to contract to protect it. That is why it's called the stretch reflex. The object is to protect the muscle from overstretch. We will use that in PNF, and I'll show you when we demonstrate it. So myotatic stretch reflex protects the muscle from stretching too far. Yep, absolutely. So Brooke made a good point. So is this like twisting your ankle, how it pops, like snaps right back in really fast, right? Your ankle automatically kind of goes back to neutral. That is the stretch reflex. That's literally, what that literally is your peroneal group says, ow, you're stretching me too far, and contracts to bring that foot back into place, right? And brings you kind of out in the eversion. Yep, that is your association. I like it. That's different than the inverse myotatic or the Golgi tendon reflex. Now this one involves length and tension. So what this says is, when I contract a muscle, if there's too much stimulus, if I have too much weight, right? So I'm lifting too much. Oh my God, this is too heavy. What is the Golgi tendon reflex going to cause to happen?
It to relax?
Yes, right? And some of you may have encountered this at the gym, or you may have seen somebody, right? You've seen that meathead over there. He's like, and all of a sudden his arms just go limp. Right? That is a firing of the GTR, the Golgi tendon reflex. This is not the GTR that Nissan produces. This is the one that our body produces. So when the tendon itself, because when we're stretching, we typically cause damage to the muscle body itself. When we're contracting, that's when our tendons are most at risk for damage. So if we contract and we hit a point where that muscle contraction is actually causing that tendon to start pulling from the bone, the Golgi tendon reflex kicks in and says, okay, I can't contract anymore. I need to relax or I'm going to rip off the bone. And so it causes the muscle to just go, bloop. It acts as, yep, go ahead.
I was just thinking about the stretching versus like contracting.
Yep.
Is like the tears and the ruptures the only thing that happens with when you're contracting, or could something else happen as well? Like in terms of like with stretching, it's like obvious to me that something would tear or rip or rupture, but with like when you're contracting your muscle, is it releasing just to prevent that, or are there other things too?
I mean, there's also part of the Golgi tendon organs also detect at the bone itself. So to protect bone fractures as well, right? There's a certain amount of feedback between the bone baroreceptors and the Golgi tendon organs. Does that make sense? Yeah, okay. Does hormone get released with that? I don't think there's a specific hormone. I would not doubt though, Brooke, if we actually detected when the inverse myotatic reflex fires, that's what I was going to say. I would not doubt that when that happens, that there might be some relaxin fired. That wouldn't surprise me. I don't know. I may have to look that up because I'm not sure about that. But I would not doubt that there's some relaxin hormone release at that point. Because oftentimes, when you think about it, when you get to that point of fatigue, oftentimes you can't use that muscle for a little while, right? Yes, Mr. John, and I'll answer Joe's question.
Is myotatic reflex, is that separate from like just the muscle being tight, or like, or at least the
Well, yeah.
antagonist muscle?
So if the muscle's tight, your myotatic reflex might be more sensitive.
Okay.
Right.
it's
So
still,
yeah, it's still there. So if I've got a tight muscle, it might actually be more sensitive to stretching and cause me to spasm a little bit more when you're trying to stretch me. For sure.
okay, makes sense. Thank you.
Yeah. So Joe asked, could dehydration accelerate this? Absolutely. Sure. It could do one or the other, Joe. It could either accelerate it or it could decelerate it. Because if I'm dehydrated, a lot of times I may not have enough potassium and sodium in there to actually fire off these reflexes. And that could also cause me to injure myself because the muscles themselves aren't detecting the movement as well. So the nerves aren't getting enough sodium potassium pumps firing to send the signal down. Does that make sense? So it could go either way. What I tend to find is that people that are more dehydrated are more sensitive to the stretch reflex. But again, it's anecdotal. Right. So I can't 100% say that's exactly what causes it. But yeah, you can have lockups and stuff like that to happen. I wouldn't doubt that the inverse myotatic here probably has something to do with cramping. But again, I haven't done enough research on it to say that it does. So again, myotatic stretch muscle spindles protects against excessive lengthening. Inverse myotatic, Golgi tendon organs, Golgi tendon reflex protects against too much contraction. So I do have some pictures on here about that. But again, if you remember those 3s and 2s, that helps you when you get a weird question, because what the board might ask you in the way they would get very, very tricksy about this. Let me get my little drawer up here and get some text. So the board may say something along these lines. Patient is performing muscle or bicep curls. Okay, so this would be okay, so I got some D's, good. This would be a great way that they will cover this. Because when you look at A, B, and C, what is A, B, and C?
It's the same thing.
Yeah, they're all the same. Right, now they may put 2 or 3 of them in the same, they may put 2 of them in the same. But this is where you kind of get confused, like, okay, so contraction goes back to Golgi tendon organs, that's 3 letters, that's inverse myotatic. That would be the way I would want you to think through this question. You could also go along and go, oh, well, wait a minute. You know, A is the same as B is the same as C, so my only option is D. Either of those ways would be viable ways of answering this question. But do you see how they could try to trick you that way really quick? Because here's the deal. You're looking at this and you're like, oh, I just erased that. I didn't need to erase that. Can I undo? There we go. You know, you might look at that and go, oh, well, oh, God, myotatic. I don't remember which is myotatic or inverse myotatic, and I'm getting stuck up on those words, right? So it's better to be able to kind of parse those out and understand the question. So this is just kind of looking at the actual muscle themselves, right? So this shows that that muscle spindle here is in the center of that muscle belly, right? And the Golgi tendon is out here at the end. Now, let me take this a step further in PNF. if I wanted to use tapping, so tapping is tap, 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 in order to help facilitate stretching. So tapping is going to desensitize something. Where would I want to tap on the muscle? The spindles. Good. Right? So that means I'm going to kind of come mid-muscle belly and start tapping. What that tapping is doing is using which theory again?
Gate.
Control.
Gate. Yeah, good. Right, that gate control theory. You're desensitizing that spindle and trying to distract it from you stretching the muscle. So in the case of like John just asked, well, what about if the patient has a really, really tight or really contracted muscle? If I'm trying to stretch that person, he has a much more sensitive muscle spindle reflex at that point, right? Or a stretch reflex than somebody that's kind of loosey-goosey, maybe, you know, like I'm stretching Raquel out or something like that. And so he's going to fight me a little bit. But what I can do is I can come in and tap on that a little bit and say, okay, come on, come on, come on, come on, come on. There we go. And I'm tricking that muscle spindle and keeping it from firing. Eventually, I'm going to hit a point where that muscle spindle might fire and inversely contract the muscle. But I'm trying to kind of calm it down enough that I can get a little bit more motion out of it. So then if I tapped that at the Golgi tendon organ, I wouldn't get that same reaction. It could be, yeah. I mean, and so there's a couple of theories on tapping as well. One of the theories on tapping also is that if I tap it, I kind of cause micro trauma to it, which increases blood flow to it, which would also help hypertrophy. If that makes sense, Truman. Yeah, and so I haven't seen any research on it, but I talked to a bodybuilder that does that. I'm like, why? So I've seen him where he has like two guys on either side of him. He's doing curls, and he's got them pounding on his muscle as he's doing curls. I'm like, why are you doing that? Well, it builds up muscle. Okay. Right? Yeah, I'm like, okay, why does it build up muscle? Because I read it in Muscle Mass magazine or something. Anyway. So my muscle spindle's here in the body. My GTO's out here, typically at what's called the musculotendinous junction. And it does receive signals, again, from all those nerves kind of down here at the distal end as well, and also some of the bone baroreceptors, so pressure receptors. So looking at both these, by looking at where they occur, you can see they are not related to the brain. So that means these are what type of a reflex?
Is
There.
it like
The
two arc?
GTO.
Hold on, I got her two of you at the same time. Pick one at a time. So the two arc, there we go. Good, yes. Right, the other term for that is spinal cord mitigated, meaning that they're controlled at the spinal cord, right? It doesn't have to go to the brain to think. Because think about that, if it could go to the brain, could we override it? Yeah, there's no interneuron, very good, right? If it went to the brain, theoretically, we could override that reflex and cause damage. This is why it only happens at the spinal cord, is so that we can't override it and cause more damage. Right? It's almost like, what other reflexes did you learn about like that?
The patellar, like all the ones where you hit with the hammer and stuff.
Right? The deep tendons, right? So that begs a question. What do you think you're smacking when you're smacking the deep tendon reflex?
The Golgi tendon?
There you go. Yeah, you're smacking the GTO. Because think about this for a second, really quick. You smack that GTO, it causes the muscle to contract. Right, you're smacking the GTO. All right, getting off the GTO and the inverse myotatic. You do have to know those. Again, I try to make them as easy as possible. The boards love questions on them, and I'm still to this day teaching the other group about them as well. So if you feel overwhelmed, it's not really a big thing. That actually is an overwhelming topic. And I've had to study a lot to kind of understand it. And I think I understand it way too much, so much that I might confuse myself at this point sometimes. So what are some goals of PNF? We can use it to enhance postural response or normal patterns of motion. We can use it to enhance stability or mobility, or both. We can use it to strengthen or stretch muscles. We can use it to improve posture, balance, and coordination. And here's the neat part about PNF. It can be used with patients with normal or abnormal cognitive abilities. That's the neat part about PNF is the patient doesn't have to be cognitively with you to do PNF because, again, most of the motion in PNF is going to be spinal cord mitigated. So, yeah. Right? So it's kind of interesting that we can even use those reflexes that we just talked about with a patient that may not be fully with it. So manual contacts, these are the key thing here when we get with patients, and that's manual contacts are touching the patient, right?
Mr. McKeever, sorry,
Yep.
sorry, before I like forget, would you
Nope.
do this like the PNF, like more of an in setting?
Yeah, I do PNF a lot more inpatient.
Okay.
But if you ask Dr. Vreskin, she does PNF with a lot of her performing arts people too. And if you ask her why, well, because again, like I just mentioned, it's very much dance-like, right? And so it's very much a method in which they're moving already. So it enhances their movement that they're already doing. So she uses PNF pretty heavily in performing arts as well. I would say I use PNF more frequently in inpatient than I do outpatient though, for sure. And I actually do use it a lot with kids. Mainly because, again, it's more of a primitive reflex, going back to that kind of primitive reflexes of pediatrics. So I can use some of those primitive reflexes to help me do things and trick the patient. I can be very tricksy hobbit. So manual contacts are where we touch the patient. A lot of times, motivate too, yeah. A lot of times we are going to use this grip right here, which is known as either the duck grip, because it looks like a duck, or the lumbrical grip is the technical term for it. Lumbrical grip because we're using a lot of our lumbricals in our hand. We do not grab people like this in PNF. This is no. This provides too much manual feedback. That's why we're going to use very soft hands, right? And also when I have my hand like this, it allows me to slide up and down the limb really easy because I've kind of got a circle to slide with. The best points of manual contact will vary by patient, right? If I'm working on a patient that has an upper extremity stroke where it's more of their far upper extremity, I might be contacting more up there than down here. Or if I've got somebody that's got a further kind of hand injury, I might be out there working more than up in the arm. So manual resistance, we're going to provide direction, quality, and quantity of resistance is going to be adjusted in order to provide a smooth and coordinated response. What that's saying is when I am providing resistance in PNF, I don't want it to be hitchy. So I don't want it to kind of be spasming as they're moving. When I'm providing even maximum resistance, so if I'm working with, who haven't I called out in a while? So I'm working with Kersey, and I really want to strengthen. I don't want to provide so much resistance that as we're going through the motion, this is happening, shaking's occurring. I want to back off my resistance so that the motion is still nice and smooth, but I'm providing maximal resistance while being smooth. It's all about that nice, consistent resistance. That is going to take time. The first rep may be hitchy. I may be kind of going a little bit, they may be shaky, I may be a little shaky. Until I'm like, okay, so I got to back off. Okay, good. Now feel that move through. And I'm backing off a little bit, but still providing them with maximal resistance. If I'm going for power, am I going to do more resistance or more reps?
Reps? Oh no, resistance.
Good, I'm going to do more resistance, right? If I'm going for endurance, I want to do more reps. Right? Or more time if I want to base it on time as well, right? Because some of the motion we'll actually do in time-based versus rep-based. The quality of movement is important, and we always want to observe for spasticity. And spasticity is that kind of shakiness, right? We start getting that kind of motion where it looks like they're kind of having a seizure in their arm or their leg. We got to adjust it. It's got to be nice, smooth quality of movements. This can be a major mistake that especially people that are, people that get into physical therapy that are kind of bodybuilders or resistance trainers kind of make, is a lot of times those people don't understand that they're no longer working with themselves, right? I'm not going to use it. Anthony goes from, being a power lifter at the gym into physical therapy. Oftentimes those type of people have a real difficult time understanding that little Millie is not his buddy Bob that he works out with at the gym. And he has a hard time toning down some of his resistance. I'm not saying Anthony would, but I'm just using it as an example. So you've got to be really cognizant, especially when you're doing PNF, of, okay, I've got to go to the patient's level, not to my level. I'm pretty confident if I'm doing PNF with Diana, I can provide so much resistance to her that she's not able to move. But that doesn't do her any good, because at that point, she's no longer getting anything out of the exercise, right? I've got to adjust my resistance to her. And if I'm providing so much resistance that everything's shaking and she's trembling and sweat's beating down her forehead, I'm not doing her a service. I've got to make sure that as I'm going through it, it's nice and smooth with enough resistance if I'm building power to provide her with a challenge. With PNF, yep, go ahead. Nope.
With the PNF techniques, can you recommend that, or does your PT have to give the okay?
Well, I mean, so, sorry, my voice was getting cracky there. It depends. If the PT has said to do exercises with a patient, PNF is exercises. So technically, you really don't have to get PT approval. I tend to tell them I'd like to do some PNF with this patient, and most of them are like, sure, go ahead. I like those movement things, the diagonal stuff. Yeah, that's exactly what I'm doing. So it's not really, it's no different than doing resistive range of motion, right? So if I'm doing strengthening where I'm going to resist you moving through shoulder flexion, PNF is not all that much different, except I add some rotation and some diagonal movement. So yeah, I mean, do you really have to get PT explicit permission? As long as the plan of care, we can relate what we're doing back to the plan of care, not particularly. But if you have those PTs that are really kind of sticklers, yeah, you want to get their approval. So it just depends upon, again, your PT. And I was talking to, I think, John about this the other day. One of the PTs I work with, literally, this is his plan of care for me. There's the plan of care, figure it out, McKeever. He writes up his eval, he gives me the goals. I've got to come up with everything. I'm okay with that. But some of you, if I did that to, Bianca, she might get a little kind of intimidated because she's like, well, I'm just learning. I don't know how to do something like, I've also done I've been in the field a lot longer I've been in the field probably as long as some of you have been alive. So, I've got a little bit more experience in that, but I've also had PTs that toss me a chart and say, this is what I want you to do. Do not vary from it. Okay, you're the boss. Yeah, John.
So if PNF is, kind of assists with functional movements, why isn't it something that we start off with instead of just like one muscle, one motion? Because
of training. Honestly, a lot of PTs just don't understand it. And again, so I'll answer that in a second, Riley. So a lot of PTs, and what I've seen from PT school, they get less than I'm giving you here on PNF. And the reason I give you this is because I've had extensive training on this, and I think PNF works really well and can be really a benefit, a little tool in your cabinet that maybe not everyone else has. And so this might be something you can pull out and say, hey, Mr. McKeever was talking about doing this with the patient when you're out in clinics. Can I give this a try? And the PT's like, sure, why don't you show me? And then you've got a little kind of feather in your cap because now you've got something that you showed somebody that's been out in the field for 20 years.
Exactly. So why isn't it more, taught more?
Because we've got blood flow restriction. We've got primitive reflex therapy. We've got muscle energy technique, which really is just PNF modified. I don't know. I don't have an answer for that other than the fact that it's kind of like a posterior total hip. that why do we keep doing posterior total hips? Because it's the one that's always been done, and it's kind of the same way in the clinic. Why do we keep doing just standard range of motion? Because it's always been done that way. I don't know. I'd be curious if we open a clinic that just did PNF, if we could outpace a clinic that doesn't do it.
Yeah, it just seems more efficient, you know?
It does, 100%. And that's one of the reasons I like it, is because, you know, if I'm doing it, I'm getting internal, external, flexion, extension, and abduction, adduction in one movement rather than having to do 5 different movements. It does, you'll see when we get into the patterns, so like, oh, well, this is like all of our body movements combined. Yeah, why would I do 20 reps of this, 20 reps of this, 20 reps of this when I can do all of them at one movement? I don't know.
So when you're doing,
Yep, go ahead.
sorry.
No.
So when you're doing like the techniques, you could use cables or bands to help them.
Absolutely.
So you know how you say like if you don't know what exercise to use, can you just use this?
Sure. Yeah.
Okay.
Yeah, I mean, this is another tool in your toolbox. That's what I'm trying to give you. And so Riley asked, how long have I been a PTA? How long have dinosaurs been around? I'm just joking. I started my career in PTA in 2005. Yes. I actually started studying in 2005. So I guess I started in 2007. So I know that you're not all that young, but I'm just saying I've been around the block a while. I've been in PT since I was a kid. Just saying. I feel like I've been trained in PT since I started football. But yeah, so before that, a lot of my studies have been just martial arts based, and it's amazing how much my martial arts skills have come into play with these. So body position and mechanics are going to be big. You are going to position yourself in the diagonal that you're moving with. And the main reason is you want to maintain good body mechanics, because if you don't maintain good body mechanics with this, or actually with any other technique, you become patient number 2. Right? If you don't have good body mechanics and you're constantly hunched over or constantly bend in with the waist, you're in the bed next to the patient in a few days, right? We want you guys to all have long, illustrious, magnificent careers in the PT world. I don't want you guys to become kind of the old cranky PT that's got damage to his back and can't do anything. So radiation we talked about is called that overflow. That's the spread of energies from one agonist to another agonist or antagonist within a pattern. It's energy, right? A lot of this, for any of you that have studied the martial arts for a long time, where you've talked about ki flow or chi flow, where you've talked about energy flow. Yep, that's exactly right. A lot of this came from that. We just don't want to necessarily say that's kind of where it came from, because again, that's untested, unproven, although I could go into whole things about that, but I'm not going to. It's just looking at, if I move one muscle, can I fire another muscle? And you can. Bilateral combinations of extremity motions have different effects on the trunk. So if I move one to one way, one thing happens. If I move another way, another thing happens. And this ties back to those ATNRs and STNRs that you guys learned about back in reflex therapy, you know, with pediatrics, right? So what it says here is if I do asymmetrical movements, it promotes trunk flexion or extension with rotation and lateral bending. So without knowing the movements too much, and I'm just going to use the upper extremity as an example. One of the movements goes here, and one of the movements goes here. So if I swap them and I'm doing opposite movements, I actually can extend the trunk by doing the movements, and my trunk goes with my arms. If I do symmetrical movements and do them together, it stabilizes my core. And I can actually get different types of trunk motions just from doing arm and leg movements. So I get the core firing even when I'm just doing simple motions like these. And again, John goes back to, well, why aren't we doing these more frequently? Because people don't like it. Verbal cueing. All cues should be clear, concise, and appropriate to the patient's comprehension. When we are doing PNF, we use a quiet voice for relaxation, a louder voice for greater recruitment of muscles. So your voice needs to fluctuate based upon what you're doing. If I'm working with John because John has spasticity and I'm yelling at him, all right, relax, relax, John, relax, relax. He's not going to relax. I'm going to spasm more, right? But I'm like, okay, relax. I tone my voice down. And this is really hard for me, to be 100% honest, because my voice is just naturally loud. My neighbor gets an education every time I'm teaching you guys. My voice just carries. The hospital that I used to work in used to joke, they're like, I heard you working with a patient in 301 and when I'm on floor 7. So you've got to adjust your tone based upon what you're treating, right? It is. It's really hard. It's hard, Amanda. It's really hard to adjust your voice if you've got that type of voice. But you got to go, okay, so relax. Most of the commands in PNF are going to be single word commands because they're simple. I want you to hold, all right? Push me, pull me, relax. Up and in, down and out. Up and out, down and in. Very simple commands that make sense. And you'll see this. Visual cueing is also equally as important. The patient should always look at their limb and see the motion during motion. Mirrors can be really useful for that. So if I'm doing patterns with the hand, I should cue my patient to watch their hand the whole way through the motion. When they're doing that, that also triggers a responsive rotation in the trunk, which then I can use. So we talked about approximation, compression of the joint surfaces. If I have a problem where maybe I've got an unstable shoulder and I'm doing the patterns with them, I may put a little bit of an approximation force on that shoulder where I'm kind of holding that better in the socket while they're doing the motion so they can build up that strength of holding it in place to increase their stability. If I've got a patient that has a little bit of tightness in the shoulder and they have a lot of pain, I may give a little bit of traction and give a little bit of pull on that shoulder so that when they're moving through the motions or doing techniques that they get stuff, they decrease pain. And then we're going to talk about quick stretch. This is the one I love to demonstrate to you guys because the quick stretch technique that facilitates the muscle spindles and keeps them from ripping. I'll pick somebody in the crowd that I can demonstrate this on. And again, this is a technique that you're going to learn from continuing ed. I don't necessarily want you guys going out and doing quick stretch because what a quick stretch does is I can actually teach it to a patient. I've got to move my chair a little bit so I don't smack myself. But I can teach them, one of the patterns goes down and out and up and in. I can teach them to use quick stretch so that when they go down and out, they get a popping motion going on that causes a reflexive contraction the other way. And I will do that with patients where I come out here, out, pop, and it automatically triggers. I almost did nothing there to trigger that to come up and across. That's just a reaction because I pop my elbow. It is very much like a ballistic stretch at that point, Anthony, right? It triggers that kind of that reverse contraction. It is ballistic, but again, a ballistic, you kind of bounce with it. With that one, I'm literally triggering that muscle spindle so hard that it causes a reaction up and across. And the first person I do that with, usually the rest of the people in the audience are like, that looks scary. Because it looks like I'm literally gonna, like if I had Anthony as my patient, it looks like I'm ripping his arm off. But in reality, he's like, I just felt that the muscle contracted. Because what I do is I do a quick pop. It's almost like a joint mobilization, right? But we are like a grade 5 joint mobilization, but it is not. I do not do grade 5 mobilizations. Dr. Freskin does not really care for those. She definitely does not like the quick stretch pattern. And I can understand, again, it's mainly because it takes training to do it. And I've done PNF quite a bit. What are some contraindications or why we might have precautions? Inflammatory arthritis, specifically in an acute stage. So if the patient's got really bad osteo or really bad rheumatoid arthritis, and they're in an acute flare, we really don't want to do a lot of PNF with them because it can cause it to flare worse, just like anything else, right? I mean, that's no different than anything else. A tumor in the general vicinity. If I'm doing upper extremity stuff and they got a tumor in the shoulder, I don't want to do it in that shoulder. But if I'm doing PNF of the legs, they've got a tumor in the wrist, that's really not a big concern as long as it's been cleared by the PT. Bone disease, any patient with really bad osteoporosis where the bones are really hollow, due to the torsional component of PNF where we're kind of twisting and moving through it, it can cause fracture. So we got to be careful if they've got extreme osteoporosis. If they've got a bone fracture, right? I mean, I don't have to say that, especially if it's unstable or comminuted. We don't want to be moving it around. Or congenital bone deformities where they maybe have a congenital elbow fusion or a wrist fusion. We just got to be careful with those. Does that mean I can't do PNF of the elbow? No, I can't. I just got to make sure that I don't do anything with whatever bones are fused, right? If I've got somebody that's got a triple arthrodesis of the ankle and I'm doing lower extremity PNF, I instead stabilize the ankle so I know that it doesn't move. The other thing I'll say here also is pregnancy. It's more of a precaution. I didn't add this one. That's an A. There we go. I can spell today. Why do you think I'm going to say pregnancy is a precaution for PNF? Yeah, the trunk flexion is a big one. Good, right? Because I'm moving that trunk around and quick movements can be dangerous. Yeah, right? So all of that. And now if I'm doing slow and low PNF, sure, I can do it. But again, I just got to be careful. You know, when you're treating obstetric patients, you really have to think about what you're doing with them and how it could affect baby. That's the major thing that's all. Yeah, we don't know how it's going to affect the fetus. You're right. I mean, that's what I'm saying. So we have to, that's one of the things we have to kind of think of. Okay, you know, I'm working with Sue Ellen and Sue Ellen is pregnant. I look through my plan of care as PTA and go, man, you know, I don't really like that exercise. And I may mention to the PT, hey, you know, Sue Ellen's pregnant. If we're doing this, this could potentially cause a problem. And PT is like, oh yeah, you know what? I didn't even really think about that. That happens quite frequently, actually. Where PT is just kind of, you know, they're writing the plan of care late at night after they've, you know, been through a 12-hour day, and they put something on there not thinking about it. That's why we've got to kind of be cognizant when we're looking at the plans of care. So PNF patterns themselves, we're going to start with the simple and work to the more complex. The patterns are the simplest part of PNF. Nice. If you ask most clinicians, they'll say, oh yeah, those diagonal pattern thingies. That's PNF, but there's more to it. It's way more, and you can spend literally hours. I was looking at the IPNFA, which is the International PNF Association. I linked them on this PowerPoint. I want to say I saw that to get certified, it's like a 19-week course or something like that. So there's more to PNF than just the patterns. The patterns themselves are named for the most proximal joint segment moving and the direction that proximal joint is moving. So you'll hear D1, diagonal 1 flexion, diagonal 1 extension, diagonal 2 flexion, diagonal 2 extensions. What the D stands for is diagonals. They are both upper and lower extremity movements, but there are also head and neck pattern movements and trunk movements and scapular movements and pelvic movements that go along with them. We mainly focus on just the upper extremity and lower extremity. But again, if you take advanced PNF courses, there are techniques that you're going to move the head while they're doing the motion that moves the trunk, that moves the pelvis. We're going to hit it at the most basic level. So now I'm going to talk about, before we get into the patterns themselves, it says the patterns are named for the most proximal joint segment moving and the direction that proximal joint is moving. If I'm doing PNF of the upper extremity, so of the arm, what is my most proximal joint?
glenohumeral.
The glenohumeral. Good. Awesome. The shoulder, right? Shoulder knew that by now. Something's never going to get old. And then at the leg, it's obviously the femoroacetabular or the hip joint, right? That is important to grasp now, because when I tell you D1 flexion, it means the shoulder is moving into flexion, or it means the hip is moving into flexion. If I say D1 extension, it means the shoulder or the hip is moving into extension. There's a ton of other movements that go along with it, but those are the control movements.
Bless you.
Thank you. I saw that coming like a mile away. So if I say, again, I'm going to say this again, I'm telling you, we're going to do D1 flexion of the upper extremity. What joint is moving into flexion?
Oral.
Yeah, the shoulder. Good. All right. Whew. If I can get you to get that, the rest of it will make sense. Maybe. All right. So this is kind of this is actually from Voss and Cabot. This was their basic pattern. I promise, we'll get it. I don't know about you, but this means absolutely nothing to me. Like, and I've studied PNF. I understand what they're getting at, but this definitely is not a basic pattern. I'm looking at this going, what the heck are you trying to say here, Cabot? So I made it kind of simple for you, and I put them into PowerPoint slides with links to videos. You're welcome. I would take all 4 of these slides. So I have D1, I have D2 of the upper extremity, and then we'll go down here and I have D1 and D2 of the lower extremity. I would take all 4 of these slides, I would print them off individually, and I would put them in that clinical binder of yours, because that way you have them for reference. We are actually going to do that on Monday, 100%. I'm just going to demonstrate briefly today, but we're going to do these together, or not Monday, Tuesday. We're actually going to do these all as a group Tuesday, so get ready. I want to talk about them. I kind of tend to talk before I teach. I'm going to show you before I tell you what to do, and then I'm going to have you do them. Mainly because actually Tuesday they're doing fumigation in the room. That's why I thought about that, John. But I actually found out they're doing fumigation, and we don't want to definitely be there when they're fumigating. They're getting the classroom ready for us. So one of the things they're doing is they're fumigating the room, they're cleaning the room sterilely, and they're also putting in huge HEPA filters in the room in order to kind of prevent, so that when we get back, because July is kind of our first time back to campus with full staff. So they're getting everything ready so that when we get everyone back to campus, you guys are as safe as you can be, which I actually appreciate at least. We've actually changed the classroom around a lot. You'll see when you get there. I think Diana saw some of it. We're still modifying some of it. All right. Well, yeah, the folk that we're not going to break up into groups. We're going to, when we go back to full lab, it's everybody. So when we go back to labs in, I think it's like July 13th or something like that, we go back as a full group. So everyone's going to be there for 4 hours of lab. Get ready to deal with me. And Dr. Reskin too. I know, right? Oh God, it's going to be hard. All right, so I'm going to give you my method for remembering these to start with. I'm going to tilt the camera just a little bit. I'm going to go out to the other camera then as well. So before we get into any of the actual specifics of this, okay, there are 2 ways I remember this. There is D1 and there's D2, 2 different diagonal patterns. D1, which is the one I'm going to talk about first, the way I remember D1 is eat the apple, and then throw it away. D1 is also known as the self-feed pattern. So a lot of patients that we have that are having problems self-feeding, meaning they can't eat alone, this is one of the patterns we will work on with them with. So D1 comes up and across into the body. So I'm eating the apple. That's flexion, because the shoulder is coming up into flexion, right? That's the way the shoulder's moving, is flexion. Coming up and across. And then the second part of that is D1 extension. I'm throwing the apple away. Eat the apple, throw it away. Eat the apple, throw it away. So when we get back to class, and actually on Tuesday when we practice this, the first thing we are going to do is just basically the movement. That's eat the apple and throw it away. We're not worrying about the rest of it. Okay, I've got the general movement down. So now I'm going to think about the movement. So when you see something that says D1 flexion, it is moving from the extension part into flexion. I can do just D1 flexion and just practice coming up and across and not really worry about the extension component. I can also just do D1 extension and only worry about the extension part of it. Or I can do a D1 flexion extension and be worried about both parts. Does that make sense? That was something that the last class had trouble dealing with. So I could do just one motion. I can literally just practice coming up and across if I wanted to. I could also just practice going away. Or I can do both. And that's going to require a lot more. Both would be easier, yeah. But if I've got somebody that's cognitively impaired, Diana, I may start with one building block, start with just flexion, right? And then start with just extension, and then combine them to build on it. In the martial arts, this is a low outside block, right? This is a ready position in the martial arts. So it comes from the martial arts, the motion. So when I move up into D1 flexion, at the shoulder itself, I'm doing flexion, adduction, and external rotation, right? So here's external rotation right here, right? So if I add flexion to that, adduction, I'm going to end up over here. The scapula has to elevate, abduct, and upwardly rotate because that's what it does anyway in order to go into flexion. That just naturally happens. If it doesn't, I can't get into flexion. So it elevates, pops up, upwardly rotates, right? And abducts or kind of moves forward. At the elbow, so the elbow is the interesting thing here. The elbow I can either do with it fully extended the whole time, or most of the time that I'm doing PNF, I will flex the elbow when I come up. So I want to underline those because the elbow is a weird one. And the reason why it's weird is because the elbow is one of the joints that often gets damaged the most. So we needed to be able to do the PNF, whether it's the elbow is straight or where the elbow bends. I prefer when I come up and across for my elbow to bend because that combines with everything else. At the radial ulnar joint, I'm supinating, or as one of my instructors said, supinating. You are supinating the elbow. It's actually forearm, but okay, Dr. Young. When I come up here and I end, my wrist is in flexion. My wrist is in slight radial deviation. Kind of looks like I'm holding a fork up to my mouth. My phalanges, my fingers, are flexed and adducted, otherwise known as a fist. So when I come up, shoulder starts flexing, adducting, externally rotating, goes with supination of the forearm, elbow flexes, fingers come together, close off, my wrist flexes and radially deviates. That's my final position for D1 flexion. D1 extension is everything in the opposite. I just reverse it. So I'm going to, at the shoulder, extend, abduct, internal rotate. Because I'm extending, my scapula is going to depress, adduct, retract, and downward rotate. When I extend the shoulder, the elbow tends to extend with it. So I usually use extension, but again, if I've got an elbow that's locked, I can keep it in flexion if I need it. My radial ulnar joint is going to be pronated, pointed down, right? So if I just come here, it's pronated. Out here, it's pronated. My wrist is going to extend. And honestly, you saw it. I extended my wrist and my fingers went with it. So I extend my wrist, ulnar deviate, fingers open and abduct. So again, that's throwing the apple away. Grab the apple and eat it. Throw the apple away. Grab the apple and eat it. Throw it away. That's the basics of it. We're going to do, again, we're going to do that more in depth on Tuesday. D2 is the technique I think of, what I call drawing the sword, draw the sword, sheathe the sword. And before anyone gets confused, the sheath or the scabbard is where people put their swords when they're done with it. So again, if it says D2 flexion, the shoulder is moving into flexion. So it's one that starts over here on my hip. So if I'm using my right arm, it starts on my left hip. It looks like I'm grabbing a hold of a sword. I'm going to grab a hold of the sword, and I'm going to draw the sword. And for whatever reason, I don't know, I'm going to throw it away. I'm going to end up in kind of a server position up at the top. Put the sword away, draw the sword, throw it away. Put the sword away. Right? The other thing I've heard this referred to as is Saturday Night Fever. And for those of you that don't know, Saturday Night Fever was a movie, I think, in the 70s with John Travolta. So John's laughing, okay? Right? It does kind of look like that, right? It looks like you're doing a 70s dance move. Again, I'm going to add this to the martial arts. This is a readying position in the martial arts. That's an upwards and outwards block. It tracks right back to the martial arts. So I'm going to start. I don't have to start in the extension position. I can start wherever, and I'm just going to go up and out. I'm doing flexion, up and out. I naturally do this because I've done PNF so long that I'm just kind of, it does it automatically. So that's the flexion movement. So flexion, I'm going to flex the shoulder, right? I'm going to abduct the shoulder, and I'm going to externally rotate the shoulder. My scapula goes along with that. In this case, I extend the elbow for this one, for the most part. But again, like I said, the elbow is designed to go either way. I'm just telling you the typical way it's done. I'm going to extend my elbow for out here. My radial ulnar joint is supinated. My wrist is extended and radially deviated if I can. Be careful because that can flare ulnar nerve. And then my phalanges are extended and abducted. So I'm way out here. And then when I come back down and in, my shoulder is going to extend. Now, this is where people get confused. It doesn't look like my shoulder is extending, but if my body wasn't here, it would go back here. My body gets in the way of truly going into extension, but it is going into extension. I'm going to extend, adduct, and internally rotate. My elbow typically goes into flexion. My scapula moves with my shoulder naturally. I am pronated. My wrist will end up in flexion and ulnar deviation, which would need to be in order to grab a sword on my hip. And my fingers flex and adduct, which is making a fist. Right? So D1 out here, feed me, throw it away. Feed the apple, throw it away. D2 here, up and out, down and in. Up and out, down and in. Now, like I said, I can combine them. And I can do motions like this, which can cause rotation of the trunk. I can do motions like this, where I'm kind of coming up in, where I bring my body together, down and out, extend the body back, flex, back. I can do motions where I cross here. Is there a necessary angle, you mean as far as the body, or degrees, you mean degree of shoulder flexion and stuff like that? Yeah, it just depends on what the patient can tolerate. Ideally, as far as you can get when you're way out here, and as close as you can get when you're in close to the body. So as far as I can get out here, as close to the body as I can get when I'm in here. Because again, when I come in close, I tend to tighten my core. Right, I bring everything in. When I open up my core. Yes, John.
What about for like abduction? Just kind of having the
as much you can tolerate. You're not going to be able to like abduct way up here. That doesn't make sense. It's kind of like almost like a scapular abduction or a scaption abduction for most of them. Again, it's working and staying in a kind of a diagonal pattern. That's the main thing you got to think about is they're going to move. If I had a dot right here on my solar plexus, I'm going to move diagonal through the solar plexus. Does that make sense? So I'm here coming across and I stay in that kind of pattern, in a linear pattern.
That makes sense. Thank you.
Yeah. basics of the upper extremity done. Now we're going to talk about the fun ones that Mr. McKeever usually falls over demonstrating. So we're going to talk about the lower extremity, and then we're going to finish this on Tuesday. The lower extremity, the first one we're going to do is D1. D1. When I'm doing this, I think of this as the hacky sack. I'm probably going to butcher hacky sack spelling. Or the hacky sack kick. I'm going to have to switch cameras for this one because I can't do this in the chair. So let me tilt this just a little bit. So the D1 is going to start way out here and come up and across. Move forward some so I don't kick my box. Way out here, up and across. So it's like I'm kicking a hacky sack upwards. I'm doing both legs, right? Out here, up and across. So when I come up and across, my hip is going to flex, adduct, externally rotate. When I come up, in this case, again, my knee is typically going to flex up here, but the knee follows that elbow in the upper extremity. I can flex or extend it. I'm typically going to flex it in D1, flexion. That's going to follow the hip. My ankle is going to dorsiflex and invert. My toes will extend. And abduct if I can, but honestly, you never get abduction of the toes because they stick together. In reverse, extend, abduct, internally rotate, plantar flex, evert, flex the toes. In, out. That's the hacky sack kick. The next one, Dr. Ovreskin really doesn't like my nickname for. So here's D2. My memory for D2 is pee on a fire hydrant. I could do them supine. I'm just doing this in standing so that yes, you would do them supine typically. I'm just doing them standing so I don't lay down. So D2 starts across the body here. So I'm going to start with my legs crossed. So I have to have some functional. Hey, wait a minute. If I have a total hip replacement, which patient couldn't I do this with?
The posterior approach.
Good job. Yeah. There might be a question about that on your test coming up. So I start way over here. And then I'm going to bring the leg up, flex the hip, up and out. And it looks like I'm a dog peeing on a fire hydrant. That's the way I remember that one. That one, I guarantee when we do that one in the clinic for back in the school, some of you will be going, okay, stop, that hurts. Because for whatever reason out here, we don't have a ton of motion. So with this one, I'm going to flex the hip, going to abduct the hip, internally rotate the hip. I do tend to keep this one in flexion up here. My ankle is going to dorsiflex and evert, and my toes are extended. And then I just reverse that, come down. I'm going to adduct, extend, and externally rotate. Extend my knee, plantar flex my foot, invert, and my toes are going to flex. I'm going to give you one key here for the lower extremity that I tell a lot of my students, and I've told the other group when I'm doing this, when you're doing the lower extremity exercises with a patient, where the foot goes, the rest of the leg goes. So if you control the foot motion, control the foot and ankle, the rest of the leg will go with it. It will just move in succession with each other. If you don't control that foot, everything else gets sloppy. So they had a great question. Do we do this in supine if the patient doesn't have balance? Sure. We're also going to start these exercises passively. Why would I want to do them passively to start?
So that you can kind of guide and train them.
Yeah, right? Test the range of motion, right? And kind of guide and train them. So this passive motion we're going to learn on Tuesday is called rhythmic initiation. What does that literally mean? Well, rhythm means doing something repetitively, right? Initiation means to do what?
Start.
Yeah, start something. So you are literally starting a rhythm with them. This is the secret here, John, and John's going to go, this kind of may tie right into John's question about why we don't do that. In the hospital, PROM is a big no-no because most of the inpatient insurances say that passive range of motion is not a skilled therapy. I would argue that it is a skilled therapy, but most insurances say it's not. But I can do PNF rhythmic initiation, which is nothing more than PROM. What do they know exactly? Which is nothing more than PROM in diagonals, and I can get paid for it. I can get manual therapy. So that's why it is a loophole, exactly, right? Well, I can't do PROM. Like I've got a patient that's a comatose patient. Well, if I do PROM, they're not going to get anything out, but I can do rhythmic initiation. And actually, in certain ways, I can even bill rhythmic initiation as neuromuscular re-ed. But I'm not going to go there with you guys yet. There are ways to do that. So yeah, it's a loophole, right? That's why I love this. We will eventually move from something like a rhythmic initiation to where the patient is doing combination of isotonics, which we'll talk about. But let's break that down a second. Combination of isotonics. What is that saying?
That you're having them move through the exercises.
Yeah, that's saying AROM. It's saying active range of motion, that the patient is doing both concentric and eccentric movement. Combination of isotonics. It's just fancy words. And we've learned from experience that fancy words people kind of avoid, right? They see fancy words and like, it must be something expensive, right? Does anyone know what this is called in the military? When it's billed, when they buy stuff? So what is this? This is a pencil. When it's on like a logistics sheet, this is a handheld communication device. You would think, right? A phone is an electronic point-to-point. Here, it's not wrong, right? The phone is an electronic point-to-point communications circuit. All right, so that's enough for PNF. Let's take a 10-minute break real quick because I know I've fried you guys here a little bit. And then let's come back and let's get into a little bit about talking about those joint mobilizations because I had a lot of questions come from that yesterday. And so let's take a break, take about a 10-minute break, come back at about 4:10, and we're going to talk about joint mobilizations and how Mr. McKeever got yelled at last night, which you guys will at least appreciate. So take 10 minutes, come back about 4:10. All right, so last night after much discussion with you guys and talking about capsular patterns and talking about external rotation, internal rotation of the shoulder and which way to mobilize stuff, I had a couple PTAs, or not PTAs, PTs, and actually a hand therapist as an OT that we had a long discussion last night because half of them agreed with me and then half of them disagreed with me. And so it was a fun discussion. Ended up a very heated debate, which I liked actually. This is my life. I like debating physical therapy. I need a real life. So what I said yesterday when we talked about mobilizations is that when you externally rotate a shoulder, that is the posterior capsule that gets tight, and that you should anteriorly mobilize the shoulder, so go from posterior to anterior. This is what started the major drama last night. Because I had another group of therapists that said, well, no, if you're limited in external rotation, the problem is the anterior capsule, and you should posteriorly mobilize it. And then I had another group that said, well, no, when you have a problem with external rotation, it's the inferior capsule that's tight, and so you should superiorly mobilize it. This is why mobilizations is so much fun. Because, yeah, right, this is the discussion we had. So we did come to a consensus on this, at least. And the consensus that we talked about was, it's not as clear as we would like it to be, first of all. And I conceded some to them, they conceded some to me. But what we did come to a consensus on is whether you are externally limited or internally limited, you probably should mobilize both anteriorly and posteriorly. So if I'm limited in external rotation or I'm limited in internal rotation, you should probably do both posterior to anterior or posterior to anterior and anterior to posterior modes on the shoulder. And the reasoning we kind of all, so we sat around and discussed this mainly is because, number one, the anterior posterior capsule thing, and one of the PTs pointed to the Academy of Manual Therapists, and the AAOMT states that when you're in external rotation, your anterior capsule is most limited, your inferior capsule is secondary limited, and your posterior capsule is tertiary limited. So I'm like, they're saying all of the capsules are limited. And when you go the other way, it's the other way around. And what the AAOMT says is it doesn't matter if it's an external limitation or an internal rotation. The problem is the capsules are limited in an anterior-posterior translocation. So what they're literally saying is whether you're limited this way or this way, the problem is front to back movement of the capsule. And if the problem is front to back movement of the capsule, you probably should mobilize both ways to loosen up both aspects of the capsule. Does that make sense?
Yeah.
Yeah. So this is just with internal external rotation. Yeah, we're going to talk about abduction in a second. Excellent question, John. So
I'm sorry, wait, are we switching to kinesiology?
yeah, I'm sorry. I thought I said that. I apologize. I thought I was continuing what we discussed yesterday. But if you have so it's a good question. So if you have a surgery, then you've got to limit your mobilizations based upon what your restrictions are.
Yeah, because I was thinking, okay, you're saying they're saying to mobilize it anteriorly, but like most people get dislocations anteriorly, right?
Yeah. So like if I
So
had a
won't that affect it?
Right. So if I had a slap repair up here where I've had an anterior surgery, I probably want to limit how much I'm stretching that anterior capsule out, right? So then I would just do posterior to posterior mobilizations to try to kind of loosen things up and not traumatize that area that has been surgery. Now, until the surgeon said I could, right? But there's some things to be said about mobilizing it a little bit like a grade 1 might help break up some of that scar tissue too that's laying down as well. So just dealing with, I'm sorry, Riley, I thought I had said loud enough. We are talking about kinesis and kind of continuing what we talked about with range of motions and stuff like that yesterday. So it was a really interesting conversation to me. That's okay. I probably didn't say it loud enough, or I'm just brain dead and maybe didn't say it. It's quite possible. It was an interesting conversation because one of the things it showed me is, although the research itself is kind of muggy on what mobilizations do, we all still do mobilizations. Like, to me, that was kind of interesting because I had thought that we'd have at least some of them to say, I don't do mobilizations. Mobilizations are dumb. There's no research on it. But every single one, there's like 8 of us yesterday on this call. And every single one of us is like, oh yeah, I do mobilizations. Of course I do mobilizations. They work. There's not a single person that said, no, they don't work, or that there's no such thing as a capsular pattern. But they're all just like, well, I'm arguing my way and I'm arguing this way. And so then we brought up the research, and I was doing research, and yeah, I need a life. But it was really interesting because literally as soon as I posted the video, I had like 3 of them watch the video, and I'm like, great. Now I've got a bunch of therapists watching my video and calling me out on crack because I'm a PTA. But it was really interesting because literally it just showed me that, yes, everyone does mobilizations. And one of them was an OTA, and she does mobilizations. So obviously it's not only limited to us, right? When we talked about abduction limitations, though, we're all in consensus on that. Abduction is typically an inferior capsule tightness, right? Because that's the one that's not letting us go this way. Where we got into the argument is one of them was like, well, it's an inferior capsule posterior to anterior that's a problem. Someone said it's an inferior capsule anterior to posterior that's a problem. It doesn't matter. It's an inferior capsule problem. Right? I don't care if it's the front side that's limiting more, if it's the back side limiting more. If I find that out, I can mobilize it the other way later. What I really am worried about is that inferior capsule is not letting me come up here into abduction. So I've got to stretch that capsule out. I've got to get it nice and loose so that I can get abduction. And the one thing all of them said that they were really happy about is, and then they wanted me to kind of stress to you guys, is no matter how often or what you do to mobilize the patient, be consistent in getting feedback from the patient. So if you're doing mobilizations, make sure you're asking them, how does this feel? Are you getting are you feeling anything when I'm doing this, right? Making sure that if it hurts, if it doesn't hurt, if it feels good, if it doesn't feel good, so that you're getting the appropriate feedback, that if you have to modify your level, that you can modify the level of mobilization you're doing. And the other thing they said is, as soon as you mobilize that joint, use the new range of motion. So if I do mobilizations posterior to anterior, maybe get the patient doing some shoulder flexion, or get them doing some PNF, where they're kind of doing everything. And then mobilize the other way, and then maybe do some more PNF and see if they've got new range. One of the therapists did bring up an interesting point, and she had stated that after mobilization, she does not do resistive therapy. And I didn't think about this, and I was like, well, expound upon that a little bit. And what her comment was is, if I mobilize and immediately go into resistive therapy, where I'm doing TheraBand or cables or weights, the patient tightens up the muscles during resistive therapy, and then I might just lose all that stuff I just got with mobilization. So she prefers doing fluid motion, just active range of motion shortly after, or functional stuff like reaching overhead, throwing a football, throwing a baseball, doing overhead serves, right? Doing stuff that's less weight related. And I really didn't think about that, but that kind of makes sense to me, right? Like if I was working with Brooke and I just really broke up and loosened up her shoulder, and then I throw a dumbbell in her hand, she's going to instantly tense up, and that could potentially just undo everything I just did. So it made sense. But Yep.
Mr. McKeever, so when you loosen them up and you have them do like pulleys or something like that, would you document? I don't know if you guys talk about that yesterday. Would you document it under assessment? Like,
if I noticed a change, yes.
Yeah, of course, if you notice a difference, okay.
Which would be a good idea for, like, if I'm doing that with you, Diana, I might say, okay, before I even mobilize you, okay, Diana, let's have you reach overhead. Okay, good. Let's have you reach out to your sides, right? Let's have you come in, and let's have you go out. And I watch how you're doing that. Okay, now I'm going to mobilize you. Mobilize, whatever I'm doing. And then I say, okay, so let's sit up. Let's see how you're doing now. And now I see you go, whoop. I've got an assessment I can now make because I've seen you flex further than you did before, because maybe you're only coming to here. So yeah, then I would put that in assessment.
And would you measure it, like use the goniometer for that?
I sure could, right? I would put the numbers in objective and then indicate that it increased in assessment.
An assessment.
Yeah.
Got it.
I could also just kind of, what's the term I want to use? I could just kind of anecdotally note that your range of motion increased too if I didn't do a measurement, right? Like noted range of motion increase in right shoulder with flexion or something like that, where I didn't actually put the amount of range. And maybe I'll put in my plan, measure range of motion increases next session, right? So that I have a thought process to get an objective measurement of it. Or maybe maybe I'll have you do finger walks on the wall and you can only go so far. And then I mobilize you and then you're like all the way up the wall with your finger walks. I'm like, oh yeah, I definitely got a clear thing. You only went up to 30 inches this time, but now you went up to 48 inches afterwards. So yeah, it does help to have that because that gives you a definite clear assessment, right? That's like, oh yeah, I did something. And the patient's like, you're magical, Diana. I love you. How did you do that to me? Right? You're just like, I'm just awesome. I brush my shoulder off a little bit there. So what long story short on all of this is that, yeah, I asked every single one of those PTs, do you expect your PTA to do mobilizations? And every single one of them said the APTA is wrong. Yes, I expect my PTA to do mobilizations. And I said, well, what mobilizations? And obviously the hand therapist I talked to said, well, shoulder mobilizations. I said, what about hand? And they're like, no, I don't want them touching the hand. Okay, right? And I said, well, why? And they're like, well, there's so much that can go wrong mobilizing the hand. I'd rather a PT do those mobilizations. Fair enough. And I'm like, well, what about anywhere else? And the ortho guy had said, of course, he's like, knees, knees, knees. My PTAs need to know how to mobilize knees. I hate having to do patellar mobilizations when a PTA can do it. Okay. Yeah, makes sense. Right. So, and again, I had 3 PTAs from Arizona, a PTA from here in Nevada, and I think 2 the OT and the OTA were from Pennsylvania that were on my call. So you guys think that I stop when I stop teaching you. I don't. I evidently keep going on for days and days afterwards and look at research. But it was just kind of interesting to hear that my theory, and it was funny, the one PT I talked to that was from Pennsylvania was actually my instructor. And she agreed, ironically enough, she agreed completely with me on the capsules because that's the way she taught me. But then as she heard somebody else say something, she goes, oh, I can understand that. Maybe I hadn't thought of it that way. And so, we're all open to change. Even I make mistakes every now and then, which is kind of important, right? So that's kind of interesting. So one of the things I wanted to show you that I didn't get to show you the last time when we were talking about shoulders and scapular things, this was what I could not find. This looks like a scary device. Does anyone know what this device is? Focus, camera.
Like a posture brace or something?
Yeah, this is a postural brace. This is a figure 8 brace. This is what I wanted to show you guys the last time about shoulder that keeps my patients from leaning forward. This is actually a prototype. I had to cover the name of the company on the back because it is a prototype. I didn't want to get in trouble with the company for showing you guys. But this brace, what it allows me to do is, somebody already said it looks like a bra. Thanks, I appreciate that. I can slip this over my shoulders and bring it down. And what this can do is I have two little kind of thumb holes here. I can tighten it up and it pulls my shoulders back and won't let me protract my shoulders. I cannot protract my shoulders. So I can't sit like this very easily, right? But it pulls my shoulders back. You could just use backpack, absolutely, John. And I was actually gonna mention that you could use that like if you know you have a problem. And it's funny because I actually had a patient that did that they started wearing a backpack for running. And they're like, you know what, my neck pain's getting better. Well, that made sense. The backpack's pulling them up into good posture while they're running. Right, but yeah, definitely could, John. This is, modification on that backpack. This just doesn't have weight with it. But the idea is it puts pressure here on the anterior shoulders, and there is a little kind of pressure thing in the back here that keeps you kind of upright. Now, there are all kinds of them in the market. This is a prototype that I'm working on that eventually is for gamers, but there's a couple of them on the market that has it. I know that there's a company called Chirp that makes these. Hold on, I'm going to knock my headset off my head. I know I am. I'm stuck. There we go. Yeah, see, that was good. Glad I didn't have hair. But it pulls me back. And I find that wearing this during gaming definitely keeps me from, he's a gamer. So that definitely does keep me back when I'm doing that. That way I don't kind of roll forward. That's one of the things I'm kind of working with on that. But that's it on that. Now I want to talk about goniometry of the shoulder, and I want to talk about manual muscle testing the shoulder. I'm not going to bring anything up because I want my big camera on me so we can talk about this. And it is on the slide. So if you pull up your kinesiology of the shoulder, I do have the stuff on the slides there for you. I want to grab my little goniometer, my little goniometer. And for any of you that didn't make it on Wednesday to grab a goniometer, you'll have another chance this Wednesday if you want to come in and grab some goniometers if you want, or you can buy them on Amazon, whatever you want to do. If I am measuring, and we're going to start with just shoulder. I'm not going to talk, remember, the scapular, clavicular area, or what's called the shoulder girdle, there's no goniometry with it. It's just pure shoulder motions. So the shoulder motions you are going to measure for me are flexion, extension, abduction, and remember, we do not measure adduction just because that's just returned to zero. That's just relaxing. External and internal rotation. There are goniometric measurements for horizontal ab and horizontal adduction, but we're not worried about those. So flexion, extension, abduction, external and internal rotation are the ones you have to cover. So I'm going to cover them in groups. So the first one we're going to do is flexion and extension for goniometry. So if I am going to measure flexion goniometry, what position do you think you're going to put me in?
A supine position?
Supine, yeah, right? So you're going to lay me back. That way I can kind of go through that full range of motion. The other side effect of putting me in supine is it helps stabilize my scapula when I'm moving, because I've got the mat against my back a little bit. It keeps me from being able to cheat in some way. Right? I can't kind of roll my shoulder up in supine. It doesn't work that way. So you're going to test me in supine. All right. So now let's think of bony landmarks. So I'm on my side here. What do you think my fulcrum is going to be? So that point where I'm going to rotate around. Anyone have an idea? I need a, okay, so I could do acromion. That's one of them I could use. And there's the other one, right? So this is key because some books use the acromion. Some books use, I think it's called parallel to the greater tubercle is what they call it. So you're gonna put it, you're gonna find the greater tubercle and put your rotational point there. Some of them will use the acromion. So what happens if you go out in the clinic and, so we're gonna use the greater tubercle here because I think that's the harder one to find. So if you can find the greater tubercle and do a motion on that, you can find the acromion and do that one. So my vertex for shoulder flexion and extension is my greater tubercle. Right, so I've got to come out here, have them kind of rotate. Oh, there it is, got it. That's my vertex. That's where that dot in my goniometer is going. What about my fixed arm? What do you think my fixed arm is going to do? So the one that doesn't move. Anyone have an idea? It's going to stay down.
Parallel to the ground?
Oh. Yes, parallel to the ground will be effective, okay? The other thing they'll say is it is going to remain parallel to midline of the thorax, right? So saying parallel basically to my body. So I find my greater tubercle and it kind of stays parallel to my body. And the next thing I hear is, well, what if somebody's bigger? Well, just go off the parallel to the ribs, okay? Don't toss these stupid things in. So parallel to midline of the body, along with parallel to floor, right? So you want to make it as straight as possible is what you want. So I kind of find the midline of the person's body, and I can find that when I passively move them through the range of motion. Okay, there it is, got it. And then what about my movement arm? So the arm that's going to move, what am I going to line that up with? Okay, good. The humerus, right? So it's going to be parallel to the midline of the humerus. And I thought I saw something up there. So Diana put it with the lateral epicondyle as kind of my endpoint. So I'm going to line it up, midline of my humerus, right? And I'm going to use that kind of epicondyle as my kind of endpoint when I'm measuring. If I need to find something to measure off of, I kind of go out and find that epicondyle and I use that to help me line up with the midline of the humerus. So I can kind of go, okay, like for me, it's not that big of a deal because I have kind of tiny arms. It actually goes to my lateral epicondyle. But like for Jason, it might actually be a little bit longer and it might not go the whole way down to hips. So you kind of go, oh, okay, now eyeball it down there with that lateral epicondyle. It's going to go up with the midline of the humerus. So those are the same landmarks for both flexion and extension. What do you think the only difference is?
Laying prone.
Yeah, that's it. So for extension, I need to be prone so I can come back past the body. Because if I'm laying on the mat on my back, I kind of got the mat in my way. I could move them to the side of the mat, I guess. Sure. But then for extension, I'm going to lay them on their belly and have them come back past the body. With both of those, what kind of stabilization are we looking at? What do we want to kind of make sure we're looking at stabilization-wise?
Their shoulder and their trunk.
Shoulder and trunk, good, right? We want to make sure that I don't do something like this where I kind of arch my back when you're doing flexion, or that I don't kind of throw my shoulder rotated or something when I'm doing extension, and that I'm not cheating by elevating or depressing that shoulder too much, right? We kind of want this, as far as that goes, it's just kind of in neutral. There is going to be upward rotation, that happens, right? But we just don't want them kind of like doing one of these to try to get more shoulder flexion, right? Rotating the trunk, laterally bending the trunk. And again, if it happens, if I'm working with Diana and she does cheat, what I'm going to say is, okay, let's back down. I don't want you to move that upper shoulder. And I'm going to kind of put a stabilization on her and not let her cheat through it and show her what it feels like so she knows what it is. And if she goes, well, I don't have as much range of motion then, that's okay. That's what you're here for, right? That's kind of the way we're going to explain it to the patient. So do flexion and extension goniometry make sense? Again, we're not talking about the numbers, just the actual, yeah, okay. So for abduction, again, adduction, we're just going to see if they actually go back to the body. Abduction, we're going to measure. One of the things, key thing though, also with flexion, whether you're doing flexion or abduction, thumb is up. Okay, so I'm doing flexion, I'm doing it this way. You don't have to have them stick their thumb out like this, but the thumb goes up. When I'm doing abduction, the thumb goes up. What position do you think I'm in for abduction?
Sitting.
Could do sitting. It's a little off.
Supine position?
Yeah, supine again. Yep. So my positions, I can actually do all of these from the seated position. And what you're going to find in the clinic is, guess what position we do most of these motions in? Seated. Why are we doing it seated? Because I can get my flexion in seated, I can get my abduction seated, I can get my extension in seated, and I never have to move the patient. Per your book, flexion is in supine, extension's in prone, abduction is in supine. And John, so remember, here's the key thing though about the against gravity is with goniometry, really don't care about gravity. We only care about gravity with manual muscle testing. Does that make sense?
It does. I was just saying, like, with sitting on the abduction, we would want to be like again, or
yeah, would it make it harder? Is that what you're asking?
Exactly.
Yeah, it could make it harder for sure, right? But if I got somebody, if I'm seeing you, right, and you just hurt your shoulder, you've got a fairly functional shoulder to begin with. I could do it in seated. If I have, little Millie, yeah, supine's probably going to be better for her, right? But I'm going to be honest, you guys are going to see a lot of shortcuts in the clinic. If you haven't seen them already, I'm sure like John and those the guys that are techs can say, you see a lot of shortcuts in the clinic, right? And we've just got to kind of, when we talk about the clinic, we talk about the clinic. When we talk about the boards, it has to be separate. Okay, so I'm going to be in supine, right? My motion's going to be like that. What about my vertex for abduction? Got a lesser tube. Anyone else? Any other suggestions? So most of the time it's going to be the acromion for this. So I'm going to come up here, I'm going to find my acromion, and that's what I'm going to go off of. And the only reason for that is sometimes with the lesser and the greater tube, when I go into abduction, they like to hide. Some of them will use that greater tube. Some of them may use the lesser tube. And that's just going to be one where if they use those in the clinic, we've got to mimic the clinic, right? But by the book, I'm just going to double check myself, because now you made my second guess myself there. Thank you, God dang it. Stop talking to you guys. No, just kidding. Now you're second guessing me. Anterior aspect of the acromial process. I was right. Good. I studied for this and I was like, wait, did I actually study for this? All right. So yes. So that's acromion is what this book says. Now another book could say something different. Stationary or fixed arm. What is it going to be, do you think? So again, I'm here, I'm on my acromion. What do you think I'm going to use for that? Good.
Would it be the same as flexion?
Okay. Pretty close. Yep. It's going to be right along the midline of the body, right?
ASIS.
Not a bad thought. Axillary border is not a bad thought. This is the weird one. So what they say is it is parallel to the sternum. So it's parallel to the midline of the sternum. So it says along the axillary border, parallel to the midline of the sternum. So yes, axillary border is technically right. Yes, even ASIS is right, because you're going to technically, if you draw a straight line down from there, it's going to go to the ASIS. Right? So by the book, technically it is parallel to the sternum along the axillary border. I don't know why, because they say so. And then my movement arm is going to go along with my humerus, right? That makes sense because that's the arm moving. And this is the weird one, because officially the point that you're going to use, and I'm not going to ask this because this is one usually most people get wrong. The movement arm, or the motion, I forgot, I'm just going to call it movement arm because I keep changing the names of it. It's going to go along the midline of the humerus, between the lateral and medial epicondyle. So when I'm up here, really it's going kind of in the middle of those lateral and medial epicondyles. It's almost in that antecubital fossa, right? That space here between, right? So it's going along the midline of the humerus. This is what a lot of people make the mistake on, because they'll come up here and they'll line it up with the lateral or the medial epicondyle. And it looks like I've got more motion. And when in reality, if I go to the midline of the humerus, if you look at that, I don't have full range of motion, do I? Right? I'm a little off of 180. And again, this is for academic purposes. You guys would have to measure this, but probably be better right about there. So yeah, I'm probably about 160. That's about usually what I am, right? If I was truly 180, I'd be way up here. Can we take, I mean, what I do when I'm doing it, and I'll show you my tricks to this when we get in clinic, right? Like when I actually can have a patient instead of myself. My one hand is going to be on this. So I'm going to have it kind of in that spot, so when they move it through, that goniometer stays with it. Does that make sense?
Yeah.
And the other thing is, there's nothing wrong with picking your goniometer up after they're up there and replacing it. Like, you don't have to constantly leave it in place. And some clinicians I find out don't. That was another conversation we had last night. Is I heard that one of the clinicians says they don't put the goniometer on the patient until the patient's in full range of motion. So that's when they take the goniometer out and go, okay, all right, there's my acromion, I find it. There's my midline, I find it. Okay, then I'm going to come out here. Okay, there's that, I find it. So there's not a wrong way to do it. I tend to leave it on just because I kind of work my way through it, but I'll show you my techniques. But yeah, so Johnson's PT that he works with does that. Yeah. For your boards, that's not a question they're going to ask you. They're just going to ask you what position the patient should be in and then their landmarks. Right. And then maybe also like Diana was my patient, may say something like, you know, your patient Diana has 140 degrees of shoulder abduction. This is considered normal or abnormal. That would be an abnormal because she's missing 40 degrees. So that is abduction. Internal and external rotation are probably the ones that I like the best because they're easy. Again, when I'm in the clinic, I'm going to be honest. I do internal and external rotation. I think it was Riley that mentioned this before. I do internal and external rotation right here. That's not the proper way to do it, Mr. McKeever. I know. That's why I'm going to tell you the right way to do it. But I do internal external rotation right here when I measure it. Even when I do manual muscle testing, this is where I test internal external rotation because I've gotten lazy, I think, and I don't follow the book. For internal and external rotation of the elbow. Yes, Oscar says I've seen that at work too, right? Yeah, we tend to find ways we can do it quick. For internal and external rotation at the elbow, what I want you to remember, and again, those are all in the show. I try to put those in there. When you're doing goniometry for internal and external rotation, the patient is supine, and they're going to go like this. When you're doing manual muscle testing, the patient is prone because you've got to add gravity. So we haven't talked a lot about manual muscle testing yet. That's okay. I just wanted to kind of, when you're doing internal and external rotation, supine for range of motion, prone for manual muscle testing, because you've got to add gravity. Does that make sense to everyone? Anyone I lose anyone there?
I thought you could do it supine too.
You could. Yep.
Like versus your both of your arms, right?
Yeah, you could. But I'm just giving you the way I'm just giving you the way the book says it. Is what I'm trying to tell you. So for your board, there are plenty of ways to do it, and there are actually your manual muscle testing book has 3 different alternative positions for manual muscle testing of the internal external rotation. I just want to make sure I stress kind of the way the boards have said it. All right, so if I am supine and you're measuring external or internal rotation for goniometry, where do you think you're going to line up your vertex? Think again.
Olecranon?
There you go. I think you meant the olecranon, Oscar. I don't think you actually meant the acromion, because that would be up here. That wouldn't do anything. Yeah, so the olecranon process. I could see your brain working there, though. My goniometer is going to be out here. Right, so I'm going to line that up with my olecranon. Olecranon. Anyway, my humor is failing. All right. Fixed arm is a weird one. So the fixed arm has 2 different possible positions. It can either be parallel to the ground or perpendicular to the ground. So I can either have it, when I'm out here, I can either have it straight up and down, where it's perpendicular to the ground, which is the way I do it, or I can leave it out at 90 and have it parallel to the ground. I don't like doing it that way, because then when I move this, I get confused. So I'm like, oh, look, they've got 0 degrees of internal rotation, when actually they went down like that. I'm like, oh, no, that doesn't make any sense. So I leave it this way. So if I'm out here, I line it up with my ulna, and it's going to be perpendicular to the ground. So again, I'm laying down. My movement arm. What do you think I'm going to line that up with? I just kind of hinted. The ulna, good.
The ulnar side?
Yep, the ulnar side. And what am I going to use as my distal end? What do I have pointing on the outside of my ulna?
Styloid process.
There you go. Good, right? My styloid process. So when I'm lining this up, Right, I'm back there on my olecranon. I'm going to try to get my movement arm here, part that's moving. I have it on top. No, I don't. Let me flip it. There we go. To line up with my olecranon styloid process, or not olecranon, my ulnar styloid process. Good. And then I'm going to measure it. So be cognizant, because let's say I go out here and I measure external rotation, and I'm like, wow, Diana's got 280 degrees of external rotation. That wouldn't make sense, right? That would be like all the way around, right? We go, oh, wait, wrong number. She's got 84 degrees. Or, you know, that type of thing. Just make sure that when you, that's the idea of looking at it first. The first thing we're going to do when we do it, we're going to move them through passive, get their end feel, and estimate how far that is, right? So if you're looking at me, and here I am with you, and I do internal rotation, what do you estimate my internal rotation to be?
$45 or $50.
Okay, so think about it. So 45, 50 would be about here, right? That's about halfway, because if I could get the whole way down here, I could get 90, but I'd have to cheat. I'm trying to not cheat.
Like 75.
Yeah, it's like 65 to 75 degrees,
Oh, right,
right?
it's at 70.
Yeah. So that gives you an estimate. So now you get on me, right? And you're like, okay, internally rotate. So let me kind of do my cheater method here. All right, that's about as far as I can go. So who said 65? Somebody said 65. 65 is about where I'm at. 65, 70 degrees. Now, if I looked at my goniometer and it said 120, then I know I looked at the wrong number, right? Because again, when you look at these goniometers, see if I can get it to focus. There we go. Right, if I go out here to 60 degrees, it lines up with 120 because those black numbers are for different ranges of motion. So I've got to be, oh, well, it's got 100, no, wait, nope, I'm looking at the wrong number. I've got to look at that 60 on the outside. And why those numbers are there is because something like the ankle, when we measure it, we start at 90 degrees. So you need those numbers to kind of add and subtract off of. But 90 would be about what we should have, right? According to the book. I think the book says, blah, blah, blah. The book says, what does the book say for? So the book says for range of motion, internal rotation is about 70. So I'm not that far off for that. External rotation is about 90. Right? Abduction's 180, extension 60, flexion is 180. I'm well off on most of those. Do those soft tissue affect? Absolutely. It could, right? I could get my fat in my way, for sure, John, right? So I may have to move it more out here to get it. Right, for sure. And again, it depends upon who I'm working with. And it depends if I'm just doing a quick range of motion or if I'm doing something for like a reevaluation. Because I'm going to be 100% honest. If I'm doing the measurements for a PT's reevaluation, I am really specific in the way I do it. I will do them in the book format. Well, no, it's true though. I'm just going to be honest about it. You know, if I do, so if the PT says, hey, you know, it says to Diana, hey, I need you to get me my measurements for my re-eval. That's when Diana's got to do things by the book. She's got to make sure she follows all the proper procedures because that's getting documented, probably sent to the doctor. If I'm doing just kind of an in-between checkup and I'm working with Oscar and, you know, Oscar's got 3 visits till his re-eval, but he's like, hey, how's my external range of motion doing? Yeah, then I do a down and dirty measurement of it and just kind of give him an estimate of where he's at. Because it saves me time from like, okay, Oscar, well, lay on your back. Okay, get your arm out here. Okay, once your arm's out here, that messes up my whole flow of things I'm doing. For range of motion, the main thing again for us is functional range of motions, right? So for eating, right, to get food up to my mouth and drinking, I need about 50 degrees. So I need a little more than just that shoulder gives me, or just the glenohumeral joint. For drinking, I need about 50 degrees. 43 is what the book says, but again, 50 is what I remember for the boards. So for eating and drinking, I just remember 50 degrees. For combing my hair, I need a lot of shoulder flexion, don't I? Get up there. And I may need some functional external rotation too. I could do it here, but it's not very comfortable. Reaching on a high shelf, almost full range of motion. The main one, and this is the big one that a lot of patients we're going to work with, is reaching behind the back. Why is reaching behind the back something that's important for both men and women?
Changing.
Scratching?
Scratching. Okay, so bra for women. Scratching's good, yeah.
For dressing.
More importantly, if I put my hand down lower.
Wiping your
Restroom.
butt.
Yeah, restroom, wiping your butt. Yeah, right? So that's kind of important for those type of motions, especially when I have limits, right? But the bra is the big one, right? For women is getting back here to be able to hook the bra. And a funny story I had about that, right before, just bring her bra. Yeah, right before I actually started teaching, I had a little old lady that she had 0 degrees of internal rotation. So literally, so she couldn't even get back there. And I said to her, I said, well, you know, they make front clasp bras and sports bras now. And she says, front clasp bras? I ain't no hussy. I ain't wearing one of them. And I was just like, I just lost it. There was nothing else I could do at that point, but just start. Yeah, I just started laughing. She's like, only them ladies that work the streets wear those front clasp bras. I ain't a stripper. And and the best part was there was a PT doing an eval across the way, and he heard it, and he actually lost control of the patient's arm and it dropped to the max. He started laughing so hard. Didn't hurt the patient, but it was just one of those funny moments you get in the clinic, right? And you're like, and she's like, I'd rather not wear a bra. Okay, then don't wear a bra, Millie. It's fine, whatever. But it was hilarious, right? But yeah, scratching your back, right? And all of us have that one spot that we need just that little bit of more internal rotation for, don't we? Or external. We get there and like, that's worse than the front class. It was just funny. I thought it was hilarious. Okay, for manual muscle testing. Famous Millie, yeah. For manual muscle testing, the important thing to remember, doesn't matter if I'm doing external rotation, internal rotation, flexion, extension, or abduction. When I am doing manual muscle testing, do not go the full way out the arm. So if I'm testing somebody's flexion here, if I go all the way out to my wrist here, is that putting a ton of torsion on the shoulder? If I'm pushing down way out here.
Yeah.
Yeah, I've got a whole lever arm here. Where would be the better place for me to put my arm for resistance? Yeah, mid-humerus, right? Or kind of right at that. I usually do the epicondyles because that gives me a good kind of lock-on point. Now, let's say I'm working with Anthony and Anthony's training for his next MMA fight. Sure, I may do distal for him, but that wouldn't be your average patient. Your average patient barely can resist you. External, internal rotation, same thing. You don't want to come all the way out here to the wrist because, man, that's even, like, do that to yourself. So put your arm out here real quick. Come up into external rotation and push down out at the hand and feel how much pressure that actually puts in your shoulder capsule. Right? Yeah. Now bring it up a little bit. Come to kind of mid-ulna, mid-radius, and now push it. Does that feel different? Right? It does. It's a little less pressure on that capsule, which means doesn't hurt as much for your patient. And remember, most of them are in pain. Less burn on the capsule, right? So real quick, just to cover the positions. If I'm testing manual muscle testing of shoulder flexion, what position for against gravity 3, 4, and 5 do you think? Sitting. Yeah, short sitting, doesn't really matter either way. I think I put short sitting on the PowerPoint, but yeah, sitting. Because that occurs in the sagittal plane, and we talked about this with all the other manual muscle testing, what position do I put them in for 2, 1, 0? Side lying. Yeah, right. Because this occurs in sagittal, as soon as I put them side lying, now gravity's reduced. It's a good rule of thumb. All right, if I want to get maximum gravity for extension, what position would give me maximum gravity for extension?
The prone position.
Yeah, good. Right. Alternate position for extension is seated. We still can do that because gravity's still here. The only difference is it's a lot easier to cheat here because I can recruit a few more muscles doing this if I'm in seated versus if I'm laying prone and my chest is kind of locked onto the mat. I can't cheat as much in prone. And again, sagittal movement, 2-1-0 is sideline for both of those. Abduction is going to be what again? So I'm coming out like this. Same as flexion, seated. Right? So I'm out here. I'm making my angel. You guys, I don't know if you ever did snow angels before, but we used to do that as kids in the snow. Right? And then if I want to eliminate, I could do side lying. Absolutely, John, I could. Sure. The only problem with side lying is once I get past 90 here, gravity's going to start helping me. So I got to be careful, but I could. I theoretically would work. And again, I'm not going to let them go the whole way up for manual muscle testing anyway. So I could see a logistic on that for sure. If I'm in the frontal plane and I need to eliminate gravity, I go to what? Supine or prone, whichever, right? Because now I've got gravity eliminated. Because now I'm making a snow angel on the mat. Internal and external rotation, I already hinted, is prone to add gravity, but almost nobody does it. No one. Absolutely no one. Everyone does manual muscle testing here. I'm going to tell you outright. Like I bet if I ask Oscar and if I ask John, they've seen manual muscle testing here for internal external rotation. Would you agree with me? Never seen it done? Okay. Yeah. The book says either. So the book says those are both acceptable positions. Yeah, the boards say the same thing. Both are acceptable positions. I tend to, when I officially want to get like maximal resistance, do it prone. But let's think about it. Most of our patients can't lay prone because they've got Dunlap's disease, right? Where their belly Dunlaps over their belt and that's in the way and they can't lay prone. So acceptable. The boards are accept either. The boards are, and again, you'll find on the boards, they're not going to ask you about internal external rotation, manual muscle testing. They're more going to ask you about range of motion because of functional movement. And then again, for internal external rotation with gravity reduced, just here seated. All right, I'm going to stop recording.